Dan yang terakhir yang kita kembangkan di sini, apa yang kita sebut dengan the new sense of bioethics. Ini pun saya mengembangkan ini distimulasi oleh sekretaris UNESCO yang di Paris. Pertanyaannya, Narto, kamu punya Pancasila, tolong etika itu dikembangkan ini. The new sense of bioethics itu adalah satu studi dari transdisciplinary subject, biologi dan seterusnya, ya. Ada sosiologi, ada economics, ada politics, language, bahkan arts, and is studying of human behavior untuk memiliki in having a new tolerance on transdisciplinary attitude. Apa itu artinya? Memang ada keterangan lebih lanjut, tapi itu setidak-tidaknya batasan dari new sense of ethics. Tadinya itu respect for person, beneficence, dan justice. 3. Berkembang menjadi 4. Respect for autonomy, beneficence, non-maleficence, dan justice. Nah, dengan the new sense of ethics ini, respect for others itu berarti respect pada antar orang dengan hewan, antar orang dengan tumbuh-tumbuhan maupun lingkungan. Ya, jadi dengan demikian respect for others itu ada artinya tersendiri, berkembang lagi. Beneficent, non-maleficent, yang kita tambahkan di situ adalah tidak hanya justice, tetapi it should be social justice for all. Itulah Pancasila.
Center for Bioethics and Medical Humanity atau CBMH merupakan bagian dari Fakultas Kedokteran, Kesehatan Masyarakat dan Keperawatan Universitas Gadjah Mada. Sebagai bagian dari perguruan tinggi ini, kami mengemban tanggung jawab untuk melaksanakan Tridharma perguruan tinggi. Kolaborasi nasional dan internasional merupakan kunci dalam melaksanakan Tridharma tersebut. Melalui kolaborasi ini pula, CBMH dapat bertransformasi menjadi sebuah pusat pengembangan ilmu bioetika dan humaniora kedokteran dan membidani lahirnya program Master Bioetika.
Oh semangat. Bela diri itu udah berangkat. Saya Mujiono, umur 45 tahun, asli warga Kampung Ricak Kidul. Saya selaku Ketua RW, selaku Ketua Paguyuban Kampung Ricak, dan selaku Ketua Relawan Kampung Ricak Kidul. Orang awam kalau sudah mendengar Kampung Ricak Kidul itu pasti akan tahu keburukan warga kami khususnya di Kampung Ricak Kidul. Karena di era tahun 80-an memang sebagian besar khususnya warga sini sudah dicap, yaitu gudangnya para gali, gudangnya para preman, gudangnya para copet, yang notabene kampung hitam atau backlist. Tetapi kami berusaha semaksimal mungkin dari kepengurusan biar Kampung Ricak Kidul itu menjadi lebih baik. Pripun kabare, Mbah? Siap napa, Mbah? Nggih, amin, Mbah. Monggo, Mbah.
Nggih, monggo.
Kula nuwun Pak Mi, wonten Mas Bayu. Wah, iki kabare yu. Dah.
Iki apa-apa ngene.
Piye kabare iki?
Ngene iki kanane ya lagi kok ngene iki.
Iki ngene.
Ricak itu orangnya enak-enak. Orangnya tuh enggak ada yang intinya nek adik gotong royong bisa enggak kaku banget. Enggak seperti yang dilihat orang di luar. Kan luar orang lihat itu wah, Ricak wis pokoke ngono kae kabeh kan gitu. Ya nek kowe wis mlebu dhewe ning kene dadi masyarakat kene ya kowe bakalane paham. Oh, jebul kok ngene iki lho Ricak. Ya mungkin masih ada sisi negatifnya tapi kan kita juga tidak bisa menghilangkan sisi positifnya toh. Kita harus melihat secara keseluruhan.
Gendang pulih pabai. Waduh, pakai apa ini Dek Kenji? Wah. Oh, pakai barongsai.
Kemarin untuk penanganan COVID, Ricak sungguh istimewa. Ricak benar-benar sungguh istimewa. Kalau yang saya alami di RT saya sendiri, kan waktu itu pemakaman budak, tidak bisa di cover oleh BPD. BPD nganti kualan. Akhirnya meninggal pagi dan sampai maghrib itu belum dikuburkan. Nah, akhirnya saya waktu itu ngobrol-ngobrol sama Pak Muji, wis Pak, adik kudu bentuk tim. Wis sapa eling gelem, ya wis tak goleki masane. Waktu itu saya ngelobi beberapa pemuda dan bapak-bapak muda yang intine ayo kowe wani ora? Wani ngopo? Ya wani makamke. Saiki nek ade ora terjun. Mesake wargane dhewe. Ya nek kuwi sesuk keluargane dhewe piye? Aku ngomongin ngono kuwi. Ya wis wani, ya akhirnya jadilah tim itu. Sesama rebukan sama Pak Muji ya wis ya dibentuk. Jadi ya alhamdulillah. Akhirnya beberapa organisasi di gereja itu gabung. Yuk bareng-bareng guyung-guyung varian Delta iki.
Nama saya Galuh, saya dokter umum di Rumah Sakit UGM. Untuk job desk saya di rumah sakit, saya kan jadi dokter umum, jadi tergantung kebutuhan. Kadang saya kerja di bagian IGD, instalasi gawat darurat, kadang di poliklinik ISPA, Yudhistira 2 ini untuk pasien-pasien COVID juga, dan juga kadang di bangsal. Kalau ditanya pengalaman selama pandemi ini, terutama kalau ngobrolin pandemi pas masa Delta ya, itu kadang kalau saya ditanya gimana pengalamannya itu masih merinding sekali. Jadi di semua tempat di rumah sakit ini tuh semuanya chaos. Saya dan teman-teman saya baik perawat, dokter umum, dokter spesialis itu semuanya chaos. Wow, ini sesuatu yang baru dan kita harus belajar adaptasi dengan cepat. Tugas kita tetap menolong pasien-pasien supaya mereka survive atau menyelamatkan yang masih bisa diselamatkan. Seperti itu. Kalau di IGD suasana itu udah kayak ICU, bukan IGD lagi. di poliklinik yang harusnya pasien bisa jalan udah kayak IGD. Bangsal biasa itu udah kayak semuanya ICU. Dan pasien itu antri di depan rumah sakit itu sudah biasa. Ada bahkan suatu saat waktu saya jaga, pasien antri naik mobil, dibawa mobil atau motor atau mobil dengan bak terbuka, kemudian tolong kami. Dengan gejala yang pasti itu COVID. Tapi IGD kami sudah full. Kami bisa apa? Kami sarankan ya ke rumah sakit lain. Ada beberapa yang mencari rumah sakit, tapi tidak dapat. Kembali ke sini, yang awalnya saya periksa, oh ini masih bisa ditolong. Oke, ke rumah sakit lain. Ke rumah sakit ini lagi sudah tidak bernyawa. Hal-hal seperti itu.
Sak gendo-gendone deknen yang namanya kemanusiaan tetap kita tolong. Mbok kuwi sing ngomong membaresah dekne sesuk lara tetap ditulung. Kan kadang-kadang ana to sing posisi wong Covid ngene iki. Ora kabeh wong iki gelem nyerak. Sedangkan wong kuwi butuh perhatian. Nek dekne ra dopeni kuwi tengene, ya kelakon mutar. Saiki 3 dino ora mangan bening jero kamar terus. Anake ora nilai. Alhamdulillah kuwi tengene pangerten. Waktu itu ambulan Delta Merbak itu memang kita tidak punya. Kita itu pinjem dari ambulan Lazismu punya Muhammadiyah waktu itu. Kalau ada apa mesti Lazismu. Tapi kan Lazismu kan tidak cuma melayani di gereja saja. Lazismu itu di semua Tegalrejo. Kadang-kadang ada panggilan di mana. Kan mereka kan juga capek, keterbatasan personil juga. Kita jaga ke puskesmas ya tadi mau dateng lah ya kangenan loh. Sedangkan ya nek puskesmas ibaratnya Bu iki butuh bantuan ini. Kono gelem telepon, mesti retine ngono. Ha kene sing nangani wong iki terus piye?
Bulan ini kita dapat waktu naiknya jumlah COVID-19 varian Delta.
Akhirnya kita berembuk sama teman-teman, ada yang mau nyumbang armada. Ya, alhamdulillah sampai sekarang masih jalan. Nek pengalaman pribadi sing paling berkesan ini mungkin kan pemakaman gue, wih banget. Itu bulan Juni guys. Jikui mayat ning Sarjito, wan banyak minta ampun itu. Yang mayat pada belum di kapan, belum kan banyak banget. Itu selama berapa hampir 1 bulan. Kayaknya diterus ke sidik ngono. Wis stres aku bugrasi aku. Psikisku sing ora kuat. Saiki gawean wis wah banget. Makam wis dina kok sampai ping 2 ping 3. SOP ini kan harusnya 1 kali. 1 hari pemakaman. nek ngomong ke sing wah jan bener-bener meh aja nganti meneh lah.
Setelah pandemi yang Delta dan di pertengahan Delta, saya tergabung dengan tim pengabdian masyarakat dari Fakultas Kedokteran untuk melakukan pengabdian masyarakat di area Krica. Nah, di situ saya merefleksikan diri bahwa kita semua ternyata berjuang di masa pandemi ini. Tidak hanya saya dengan teman-teman saya di rumah sakit, tapi semua orang juga merasakan perjuangan itu. Mereka juga sedih ya bareng-bareng, berjuang ya bareng-bareng. Bagaimana mereka bisa survive di pandemi ini dengan supporting system mereka.
Siap. Jos. Pripun Pak RT? Oh siap Pak RT, jos.
Karena saya melihat bagaimana orang-orang relawan-relawan di daerah Krica itu yang bahkan bisa jadi tidak dibayar, tapi dengan ikhlasnya membantu sesama. Itu sangat mulia sekali. Dan mereka juga berjasa banyak dalam menolong orang-orang untuk mungkin membantu membawanya ke rumah sakit. Kalau tidak di rumah sakit, bagaimana tetap survive tapi di rumah dengan logistik yang ada, dengan vitamin yang ada, dengan pantauan kesehatan yang ada. Mereka hebat. Dengan membentuk sistemnya sendiri, itu jadi semakin menguatkan saya bahwa kerjasama dari semua orang itu perlu. Di saat, kalau bisa dilihat rumah sakit ini sebagai bagian dari institusi pemerintah, tapi mereka adalah institusi sosial yang membangun diri mereka sendiri supaya kuat.
Ini mau ke Gadjah nanti ya?
Oh yuk, jalan ke sana. Ambil ngobrol-ngobrol di jalan.
Ke sana Pak.
Tapi sampai dalam rumah Pak?
Iya, sudah pernah tahun lalu sampai rumah, masuk rumah.
Itu sesuatu yang besar. Ketika pemerintah tidak bisa mengcover semuanya dan mereka dengan mandirinya hadir dan melakukannya, itu sesuatu yang besar dan saya bangga dengan mereka. Keikhlasan, rasa gotong royong itu sangat penting.
Dan bekerja, kita juga tanpa biaya, kita semua apapun gratis, ya toh Mbak. Kami sudah 24 jam untuk pengantaran orang yang mau ke rumah sakit, apapun dia mau swab, kalau minta bantuan mau ke rumah sakit, kami mengantar dengan mobil.
Dan bisa jadi rasa keikhlasan, gotong royong itu yang membuat kita survive bersama dari pandemi ini.
Good morning, selamat pagi, Assalamualaikum warahmatullahi wabarakatuh. Excellencies, distinguished guests, ladies and gentlemen, we are honored to welcome you to Palliative Care Symposium, Investing in Palliative Care, Improving Health for Elderly. This symposium is held by Center for Bioethics and Medical Humanity, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, and UNESCO Chair on Bioethics, Universitas Gadjah Mada, in collaboration with Amsterdam University Medical Centers. I'm Tia, and I'm honored for being your host today. I'm honored to welcome and to introduce you today's panelists and speakers. Professor Dr. Dick Willems from Amsterdam University Medical Centers, Zanthi de Voogd, PhD from Amsterdam University Medical Centers, Dr. Maria Astheria Witjaksono, Master in Palliative Care from Rumah Sakit Dharmais, Jakarta, Dr. Darwito Sarjana Hukum, Spesialis Bedah Konsultan Onkologi from Rumah Sakit Akademik Universitas Gadjah Mada, Dr. Christantie Effendy, Sarjana Keperawatan, Magister Kesehatan from Nursing Program of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. On behalf of the organizers, I would also like to extend our warm welcome to the representative of UNESCO Jakarta, to the Vice Dean for Research and Development of Faculty of Medicine, Public Health and Nursing UGM, Dr. Lina Khoridah, Spesialis Radiologi Konsultan, to the founding leaders of Center for Bioethics and Medical Humanities, Professor Dr. Sunarto Sastrowiyoto, Spesialis THT Konsultan, and Professor Dr. Yati Sunarto, Spesialis Anak Konsultan PhD, and all of our seniors in Center for Bioethics and Medical Humanities. And we are also honored to have you all, our invitees, guests, and participants from the Asia-Pacific countries, from faculties of medicine and hospitals in Yogyakarta and surrounding areas, and from all over Indonesia who may join us either online or offline today. Excellencies, distinguished guests, ladies and gentlemen, now we are going to have the Vice Dean for Research and Development of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, to give an opening speech. Please welcome Dr. Lina Khoridah, Spesialis Radiologi Konsultan.
Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Distinguished speaker, Professor Dr. Dick Willems and Sante de Voogd from University Medical Center Amsterdam, Dr. Maria Astheria from Dharmais Cancer Hospital, Jakarta, and also the speaker from Faculty of Medicine, Public Health and Nursing, Dr. Christantie Effendy. Dr. Darwito, Spesialis Bedah Konsultan Onkologi from RSA, Universitas Gadjah Mada, Distinguished Professor Sunarto, Professor Yati Sunarto, and also Professor Sofia Mubarika, and also Distinguished Representative from UNESCO Jakarta, invited guests from Malaysia, Bangladesh, Australia, and other countries in Asia Pacific region, and also moderator and participant of the symposium, and all other invited guests. Ladies and gentlemen, first of all, I would like to extend the warmest regards to all of you from Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. It is truly an honor for the faculty to host the Palliative Care Symposium conducted by the Center of Bioethics and Medical Humanities of the faculty with collaboration with the University of Amsterdam, the Netherlands. I believe that the topic is essential as the need to invest in palliative care and improve the health of elderly is likely to grow in the upcoming era. Unfortunately, caring for elderly comes with a series of issues and also dilemma in decision in clinical practice. And even with clear care goals, it can be challenging to achieve the goal of care while respecting patient. I hope in this meeting, all of the participants, they can improve their understanding of palliative care and also address ethical issues related to palliative care research, education, and services. This is also a great opportunity for our faculty to revitalize international collaboration in bioethics with related collaborators. And next, I would like to express our most sincere gratitude to all of the speakers at the symposium. Thank you very much allowing us to learn and also sharing your knowledge and experience for all of us. I would like also to thank for UNESCO, Jakarta, UGM Academic Hospital. Thank you so much for the support. And my appreciation also goes to the Center for Bioethics and Medical Humanities of the faculty and all related parties which made this symposium happen. I wish you all a fruitful symposium. Please enjoy and thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Lina, for the warm wishes and opening. Next, we are going to officially open the symposium today with an opening by the Director for Center for Bioethics and Medical Humanities. Please welcome Dr. Randa Ratnasiwi Patnawati, Master of Arts.
Thank you very much, Mbak Tia. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. Yeah, it's supposed to be me who reported to Dr. Lina first, so that Dr. Lina should be opening the symposium, but it's in the other way around. So I'm so sorry. Apologize for that, but it's I think it will not make the symposium less important. Yeah, thank you very much. Yeah. Yes, I would like to welcome the Vice Dean of Research and Development, Faculty of Medicine, Public Health and Nursing, Dr. Lina Hoirida, and then Prof. Dick Willems, our visiting professor from Academic Medical Center, University of Amsterdam, who has been long collaborator for the Center for Bioethics and Medical Humanity, and also later visiting professor on the graduate study program on bioethics at Graduate School Universitas Gadjah Mada. And then also founder of Center for Bioethics and Medical Humanities, and also board of the advisor, Prof. Narto, Prof. Yati, and Prof. Sofia Mubarika. And all distinguished speaker, Dr. Christantie, who is here, and then Dr. Maria Witjaksono, who will talk later online, and also Dr. Sante De Voet and Dr. Darwito, who will be also with us online. So, and also all the participants who are present in this room, our alumni also from the graduate school on bioethics, yeah, and also all participants who are online or also in this room. The UGM Center for Bioethics and Medical Humanities is honored and proud to be hosting the 2022 Palliative Care Symposium, Investing in Palliative Care and Improving Health for Elderly, from today, until end of tomorrow. Yeah. This event is also one of the output projects for the UNESCO Chair on Bioethics, where the important ethical research that then can be applied and shared with the world to create positive change. We are proud to be representing this organization and so pleased that you could share in this experience with us. This is such an important topic in contemporary bioethics and healthcare, where death and aging can often be uncomfortable topics to discuss. Palliative care, as the care, support, and services for people of all ages facing a life-limiting condition, is a medical field that requires its consideration. Scientific studies are showing that people in today's society are living longer, even with serious chronic conditions. But with this extended lifespan comes the responsibility to care and give support for those who need it. Palliative care provides option for pain symptoms management, which is crucial to the quality of life of all patients. It is actually grounded in a holistic and multi-team approach, with integrating physical, psychological, social, and spiritual dimensions of human being. So our respect and gratitude must be paid to our visiting professor from University of Amsterdam, Prof. Willems, which will be the main speaker of this symposium or this event, and also Dr. Christantie Effendy, Dr. Maria Witjaksono, Dr. Sante, and Dr. Darwito. But this event will not be possible without the contribution and hard work of many people involved in preparing this symposium. Therefore, I would like to thank Mbak Puri, Mbak Tiwi, where's Mbak Tiwi? Mbak Erlin, Mas Anggun, Mbak Dewi, Dr. Tia, Dr. Galuh, Mbak Alif, Mas Dedi, Mas Azid, or Dr. Azid, Dr. Wika, and Mbak Desi, who with a very hard work in preparing this symposium. Once again, I welcome you all to the 2022 Palliative Care Symposium. Thank you.
Thank you very much, Pusi, for the warm welcome. My deepest apology for mixing up the order. Now, ladies and gentlemen, I'm delighted to inform that today's symposium will be divided into two sessions. The first session will be about sharing experiences in palliative care, and the second session is about educating palliative care. And the first session and discussion will be moderated by Mrs. Puri Swastika Gusti Krishna Dewi, Sarjana Ekonomi, Master of Science. Mrs. Puri, please take the floor.
Good morning, distinguished guests, participants, ladies and gentlemen. I would like to request Prof. Dick perhaps to come here. We will begin the session 1. Please, Prof. Thank you. In the sofa, yes. So you are comfortable to guide us and teach us. Professor Dick. All right. Professor Dick Willems is a professor of medical ethics at the Academic of Medical Center from University of Amsterdam since 2003. With the long list of his accomplishment and experience, he has research interests and supervision of PhD students, including in ethical aspect of genetics, ethics of big data, research in medicine, palliative care, end of life issues, home care, self-management technology, and then recently you are very interested in digital technology in healthcare. Correct, Prof? Yeah, he's also a PI and a researcher on numerous projects with both national and European funding, and is an ethic advisor on EU-funded research project. Professor Dick is also co-leader of the personalized medicine program within the Amsterdam Public Health. And also he's working with the ethical and societal work package within 2 large EU-funded studies in cardiology in Europe. So Professor Dick is very, with the distinguished and all the credibilities, is very fit to teach us the palliative care and share with us his experience. The first session will be about what is palliative care and the differences between the chronic and the acute care in palliative care. So for the time and the floor, I will give it to Prof. Dick. Yes, please.
Okay.
So you didn't fall asleep?
No, I didn't. Selamat pagi, everybody. I'm so happy to be here and to be able to discuss with you and to speak to you. I think, as Busiri already said, we have a long-standing relationship. I have the feeling that it gets stronger and stronger, and I'm really happy for that. So we have several people that we work with together. We have PhD students. One of them is here in front. Bagas is fortunately here. So we're really collaborating and cooperating more and more. So that I'm really thankful, and I want to thank you. You thank me all the time, but I want to thank all of you for that cooperation that has been so fruitful for us as well. So that's maybe the first words. And before I start, I'd like to say that I was very moved by the film that you showed at the beginning. And I think it is really very appropriate to start with a film like that, because I think if the pandemic has shown us one thing, it is that people sometimes in modern times die in ways that we don't want, because there have been many, many deaths, and some of them have died in a terrible condition and in terrible situations. You have seen the images, and some of them were here, but you have seen the images from Europe and from the United States and from everywhere, where people died in complete loneliness sometimes, without even being aware of what was going on. And so I think that the COVID crisis has shown a lot, but it has also shown us the importance of good palliative care, because we just didn't have enough palliative care available to secure a good end of life for these people who were victims of the crisis in the beginning. Fortunately, the crisis is lowering now, is not that serious anymore, which also makes it possible to travel again. So I'm happy that I could be back. But so I think it was a very appropriate thing to show in the beginning of this symposium, because it has a lot to do with what palliative care is about. So you can show the first slide if you... I don't know who is going to do it. I'm going to do it, I think. Where did I... Yes. Where do I point? Somewhere in... Ah, yes. Before I begin, I'd like to say a little bit about the word symposium. We're having a symposium these 2 days, and the symposium comes from the Greek. The symposium was something that people did before the Christian era, and this is an image of the Symposium of Plato, the ancient Greek philosopher. And as you see, you're all sitting very nicely and quietly, but symposiums originally were very noisy things. So people were, as you see, they were crying, and they were some people were speaking and others were chatting. So it was a lot more noisy. So we're very disciplined here, of course, and maybe we should be very disciplined. That's very good. But why I show this image is that I hope that we will have a bit of an atmosphere of a symposium like the Greeks had it. And what I mean by that is that I would be very happy if you just ask questions if you have any. Or if you have comments, just raise your hand and start talking. And don't be afraid of talking. And especially also, please talk in Bahasa Indonesia if that's more easy for you. And I will not be able to understand, unfortunately. I'm a bit ashamed of it, but well, I'm not able. But then someone will translate for me. So please turn this into a real symposium as the Greeks had it. Okay, so where do I go with this? Or is it off? Is it off still? You think it's working? Ah, it's moving. It's already moving. All right. So I will speak a little bit about principles and values and the philosophy of palliative care, because I think in the beginning of a symposium like this, it's good to realize what the central values of palliative care are and in what senses it may be different from normal, acute, or chronic care as we know it. So, and maybe for some of you this will all be very well known already, so I may not be saying anything new to some of you, but I think it's still good to realize and to take that as a basis of the symposium. So that's why I'd like to talk about principles and values. I still have difficulty finding where. I have to turn it in. Yeah. Where's that? Ah, okay. No, that way. Then. Well, I can also ask someone to change slides if you want. Yes, I'll just say next slide and then. So let's begin. Next slide. Let's see if that works. No, it doesn't work. I'd like to have the next slide. I have to be more polite, of course. I would like to have, yes, that works. So politeness is important. So what I will do in the next, let's say, half hour, a bit more maybe, is that I will speak a little bit of the history of palliative care, and that will be a very Europe-centered part of the story, because that's all I know. I'm from Europe and I don't know anything else. So I will speak a little bit of the history, and I will speak about the definitions and the aims of palliative care and the central values that are part of palliative care. And I will speak about the distinction and maybe not so, also similarities with what we call chronic and acute care. So those are the three parts of this first introduction, let's say, or the first talk. So next slide, please. So these are just a few images of how we look at life and death. I think that the book that is shown here by Atul Gawande, who is a surgeon from, I think, New York in the US, he wrote a few very beautiful books about the practice of medicine, and one of them is about the practice of medicine at the end of life. And this book, I would really, it's available easily online also. I would really advise you to read it, because it's a very nice and very accessible book about the practice of care at the end of life. And I think that the right image shows you a bit how we tend to think of life and death. Death is the evil thing and life is the good thing, whereas palliative care is a way of also making death as good as it can be. So of trying to provide a good death. So, but can I have the next slide, please? So just a little bit of history. In Europe, around 1100, so that's more than 1,000 years ago, there were increasingly institutions called hospices, and they emerged as places of what's called hospitality for the sick, the wounded or the dying, as well as for travelers and pilgrims. And I think it's very important to realize that the word hospitality is still in our word hospital. I sometimes don't have the feeling that hospitals are places of hospitality. If you see how things are going, and sometimes you don't even feel very welcome in hospitals because of all the forms that you have to fill in and the difficulties of getting in and the long waiting lists. But at the beginning, hospices were essentially places where people were welcome and where they were taken care of if they were sick. Even if there was no treatment for them, they were still welcome. So this was a system that was existing, has existed for at least 1,000 years in Europe, and that has increased over the years. And then in the 19th century, as far as we know, there was an increasing number of this type of hospices for the sick and the dying, and they usually were run by people with a religious background, so by monks or nuns, maybe mostly nuns, of course. So they usually were ways of performing their religious duties, this care for the sick. But what is, I think, an essential thing, and we tend sometimes to forget that in Europe at least, until the 19th century, doctors didn't want to have anything to do with dying people. So as soon as a patient of them was going to die, the doctor disappeared. Because the doctor didn't want to be associated with death. Doctors considered that maybe as a failure, and still I think many doctors consider death as maybe even a personal failure. And I think that's one of the obstacles for good palliative care. If you consider death as not something that's normal and that's part of life, but as a failure, then you will never be able to take care of the dying patient. So, but in the 19th century, essentially first in the higher classes in Europe, doctors began to be present at the deathbed. And that gradually grew. So hospices also became gradually more medical, where they first were places of hospitality, which is important, but there was no medical care. And then increasingly doctors got into the hospices in Europe. And and they were called hospices, they were still called hospices, but they were not called palliative care, because the word palliative care was only developed in the 20th century. We didn't speak, nobody spoke about palliative care. And palliative has a specific meaning. Maybe you know what it, can I have the next slide, please? Oh, this is the person who is considered in Europe, and many of you will have heard of her, I think, is considered in Europe to be the founder of what's called modern palliative care. And that's also the time when, for the first time, the word palliative was used. And this is Dame Cecily Saunders. She was originally trained in England as a nurse, and then she continued her studies and became a doctor. And she was the one who had, in fact, the first major publication on care for the dying in a textbook of oncology. And this was a textbook, I think, in six parts. It was a huge thing, and there was just one chapter on the care for the dying. But that was already much, because usually they didn't even speak about people who died from cancer. So she was the first to speak about the management of patients in the terminal stage of disease, and to write about that. And then in 1967, she and others together founded the first modern hospice. That should be an S. It's St. Christopher's in London. So you see, there's still a religious background. It was I think, an Anglican. I'm not so sure, but I think it's an Anglican Christian institution which wanted to give modern and say really modern care to people who were dying, and they, with the word modern, they meant that it combined very good care and hospitality still with research and teaching. And that was in fact the first time that people thought that it could be useful to do research in palliative care. So it was not only, even though that was still very important, it was not only hospitality and good caring, but it was also doing research and teaching medical students about how to care for dying patients. It was also more medically oriented. So there was a lot more focus on the appropriate way to treat symptoms like pain and dyspnea and other important symptoms in palliative care. So this is recognized by everybody as one of the major steps in palliative care in Europe, and I think all over the world. Can I have the next, please? Can I have the next? Yes. Oh yeah, this is just an image of St. Christopher's Hospice in England. In London, it was in the center of London. So, the next, please. Can I have it? Yeah. Now, what does the term palliative mean? You may all know this. It's a term from Latin, and it comes from the word palliare, which is a verb meaning to put a cloak around someone. So in fact, it was a way of keeping someone, to covering someone who was suffering and who was in pain. So that's in fact a sort of a gentle, caring way of dealing with someone else. So putting a cloak around someone who is suffering. You don't treat the suffering, you don't do anything spectacular, but you just that's the essential, I think, the essential caring movement, gesture, if you want. Putting a cloak around someone who's suffering. So the main aim of palliative care, and I think that's still true, the main aim is to relieve suffering, make suffering less. And even if you cannot take away the cause of the suffering and change that. So that's, I think, a basic and that may also be a fundamental difference with more curative approaches in medicine, that the essential aim is to take away suffering, to relieve suffering. I don't know if there's any questions up to now or any remarks or things that you want to share in the idea to make a symposium of it. Not really. Yeah, that's okay. But maybe people would want to say something now. All right, good. So we'll go on then. But can I have the next slide? So, as you may probably be aware, the WHO has in, I think, 2009, several years ago, made a description or a definition, if you want, of palliative care. I'd like to look at that definition a bit closely and look at what kind of values are in that definition. Because we're here at a symposium of the Center for Bioethics and Humanities, so it's logical, I think, to look at the values. Because we're speaking about values. And that's one of the things that's very important here, I think. So what the WHO says, and it's a description in two parts, so you will have a next slide that will continue. No, thank you. Can you go back? That was too nice and quick. Can you go back one, please? Yes, that's the one. So what the WHO says is that palliative care is an approach that improves the quality of life for patients and their families, facing the problems associated with life-threatening illness through prevention and relief of suffering, by means of early identification and impeccable assessment, and by means of treatment of pain and other symptoms, physical, psychosocial, and spiritual. So that's the essential first part of the definition. And I made the words that I wrote down in red are in fact the places where I think there are interesting or important values as part of this description. So the first one may be that the main intention is to improve quality of life. Quality of life. It's not only quality of death, but quality of life until death. And that's an important distinction. So it's still life, even if people are dying. So it's still about quality of life. It's not quantity of life. So we don't try to prolong life at all costs in palliative care. Sometimes palliative care may be so good that people live a bit longer, but the main aim is quality and not quantity. And I think that's something to keep in mind. It's quality and not quantity. Well, it's not opposed to quantity, but the main aim is really quality of life. And so it's quality of life of patients and their families. And I think that's really a distinctive element of palliative care also, because it's not only focused on the patients, but it takes their families to be part of let's say the unit of care, if I can say it that way. So it's not only the patients, but also the families. And that distinguishes it from most of the rest of healthcare, where we focus on patients much more and sometimes forget about the families. And I think this is also a point where curative and chronic care can learn from palliative care. But because families are so important in every part of care. But here it's in the definition. So that's the families. I think what people tend to forget is that palliative care is not only about relief of suffering, but also about preventing it. So we should try to be very careful about preventing suffering by thinking about the problems that may occur in the course of a palliative care trajectory. So you should be aware that at some point people may develop dyspnea, for instance, if they have a lung tumor or something like that, and then you can try to prevent that by doing radiotherapy, for instance, in an early stage or that kind of thing. So the prevention and the relief of suffering. And many people don't think that palliative care could be preventive, but it is a preventive form of care if you do it properly. And that's one of the values here. So prevention, I think, is usually better than relief, and that also applies in palliative care. Then there's one that I forgot to make red, and that's early identification. And I think I'm going to speak later on a little bit about palliative care in the Netherlands. And one of the problems that we still have, and that you probably have here too, is that palliative care comes at the very end only. So it's at the last week or 2 weeks of life, then palliative care. If it plays a role, it goes to the last couple of weeks. And that's too late. Because you have to be a lot more early to be able to prevent symptoms and to prevent suffering. And you have to be early to be able to speak about what is important for patients, what's important for families. And all those things you can't do in the last couple of days, because then they're just too sick and too close to death. So I think one of the real challenges of palliative care in the whole world, in our country as well as in your country, is to be early and not to be at the last point. I'll get back to that because I think it's so crucial. Impeccable assessment, treatment of pain, and what I think, and I think Busiwi already said that palliative care has a holistic approach. So it's not only about pain. I mean, there's still people in the Netherlands who think that palliative care is essentially pain treatment. And some people even think that it's essentially giving morphine and nothing else. It's really a lot more than that. And I think it is, and that may be why I felt attracted when I worked as a general practitioner. I've always felt that palliative care was the most rewarding part of what I was doing. Even though I couldn't cure anybody, it was the most rewarding part, and that was essentially because it's such a holistic approach. It's both about physical symptoms and about psychological and social issues and problems, and it's about spiritual issues. And I think that's another lesson maybe for other areas of care, that in palliative care, quite naturally, spiritual and existential issues have had a very important place. And that's spiritual issues of the patient, but also of the family. Well, I will probably talk about spiritual issues later on. So that's only the first part. I mean, it's a long story. So can I have the next, please? So the WHO description goes on to be a bit more specific about some elements of palliative care. So provides relief, we already said that. This is something that I already indicated, that palliative care, as WHO says, affirms life. So it is about living. It's not only about dying, it's also about living at the end of your last period. It's also so. And what I think is really important is that it regards dying as a normal process. I'm not sure how it is here in Indonesia, but I think that most of Western healthcare is still thinking that dying is not normal. That it should be, and I think it should be avoided, of course. It can be much too early. But it is a process that is normal, that is part of life. At some point, it shouldn't be too early, but at some point it will become normal. And as we're all aging in the West, but also here, dying will have to be looked upon as a normal process much more. And then there's the third one, and that's a bit specifically interesting for the Netherlands maybe, because the WHO specifies that palliative care doesn't intend to postpone death, so it doesn't intend to prolong life, but it also doesn't intend to hasten death. So it's not intending to make death come earlier. And that obviously has a relationship to one of the big ethical issues in the Netherlands with euthanasia. Because euthanasia obviously is a way to hasten death. So death comes earlier than it would have come naturally. And WHO says palliative care does not intend to hasten death. And I think there's some friction with what happens in the Netherlands, because I think also in palliative care in the Netherlands, many doctors are not opposed against the possibility of euthanasia, even though they would be very careful about it. They're not all opposed. So, but I think it's important to realize that this is what the WHO regards as palliative care, as an element, as a central value. So then it integrates psychological and spiritual aspects. And then the last one I find very interesting too. That is, let's say, a bit similar to what I said about that it affirms life. Palliative care helps patients to live as actively as possible. So it's not only helping them die, it's also helping them live. And that's, I think, something that we should keep in mind. So if a patient wants to do certain things, then it's the role of palliative care to help that patient do them. There's quite interesting stories of patients who wanted to make one more trip to a place that they've went to very often, and everybody thought that it had become impossible, but then with the help of palliative care, volunteers and all kinds of people, it was possible to do that one last time. So, and that is what is meant by living as actively as possible. So this is the whole description of palliative care by the WHO, and I think it's usually quite helpful to realize, especially also what the values are that are part of the definition of palliative care. Can I have the next slide, please? Oh, I thought I was finished. I wasn't finished. I'm sorry, it's even longer. So you have to bear with the WHO for about 5 minutes more, maybe. I'm sorry, I completely forgot there was not another one. So it says it also helps the family cope. I already said that. It's a specific element of palliative care that it shows that it's about families. And there's another element in that first sentence, which I think is also very important, is that bereavement care is part of palliative care. So once the patient has died, palliative care doesn't stop at that point, but it will support patient. And it may sometimes, and that was something I thought about when looking at the COVID-19 film that you showed, it may also help the bereavement of caregivers. Not only families, but sometimes also professionals feel very bad about deaths that occurs. And one of the men in the film said that. He could hardly... That's the family and the bereavement part. Enhanced quality of life, I already said that. And as I already... Well, this is all things that I've already said, I think. So that it's applicable early in the course of illness. Can I have the next slide? So this one was quicker than the earliest. This is a slide that nicely shows how we thought previously about palliative care and how we tend to think now about palliative care. I think about 30, 40 years ago, when I just came into the field of palliative care as a GP, we were thinking about it according to the image A, where you go on treating what they call with aggressive intent, but let's say with the intent to way of organizing the relationship between the curative care and palliative care. Because they felt abandoned, and they thought palliative care was some second-rate thing that you only did if you had nothing else to offer. And it was even for many patients a sort of a death sentence. As soon as the palliative care team came in, they knew that they were going to die within a few. To image B, where maybe in the beginning, I'll show maybe here in the beginning, the active intent or the curative intent is most important. So you do primarily things to cure in the hope to cure the disease. But then gradually, palliative care becomes more important. And that's why I stress so much the early elements of palliative care, because you have to be, in fact, here already, or maybe here, you have to talk about the things that are necessary once curative intention is not available anymore. And you have to do that early. So there's another image. Can I have? I think this one is even better. This is about children. It's about pediatric hospice palliative care, but it's the same image. So you go on, you have this, but this is better, I think, because bereavement care stops somewhere. So it gradually goes down. Because in the former image, it looked like if that stopped suddenly, but that also has a grade, so it goes down. And what's interesting about this image is that they are already talking about grief and loss in the earlier phase of palliative care. Because, you have to realize that in the palliative phase, people already lose a lot. It's a period of ongoing loss. They can do less and less independent. For many people, the palliative phase is a phase of dependence. And so they lose their independence and everything. So grief and loss already starts here, not only there, but already here. Can I have the next slide, please? So what if we were talking about differences between acute care, chronic care, and palliative care, I think the most, the clearest difference is the difference with acute care, where you really try to cure the disease and to restore the body and the soul, I think, to the previous condition. So as if the disease hadn't been there. And I think that's the way we all get cured from common colds and from all kinds of diseases. So after pneumonia, you may be the same person again. And even after COVID-19, you may be the same person again. Even though some people have a long COVID, most people just restore to their previous condition. That's, in fact, the intention of acute care. The intention of chronic care is already a bit different. It's the situation in which the disease cannot be made to disappear. If you have a diabetes patient, they will keep their diabetes, and that applies for all chronic disease. But it can be contained, so it can be limited. Quite a different intention from acute and curative care. And palliative care is the situation in which life prolongation also is not possible anymore. That's still possible in chronic care, but it's not possible in palliative care. So the intention is to relieve the symptoms and to maintain as much quality of, as I already said, as much quality of life as possible. So it's again the focus on quality. And I think what's interesting to realize is that this goes from a quite reductionist view, where if someone has a pneumonia or a broken leg or something, you treat that organ, and the person is to some extent reduced to the part that is diseased. And chronic care is already less reductionistic, but I think palliative care is the most holistic form of care that we know of at the moment. Well, it may be others, but it goes from very reductionistic, reducing the person to the disease, let's say, to holistic. And it goes from disease-centered to person-centered, I would say. Chronic care, I think, is usually very person-centered and adapted to what persons find important. And this palliative care is even more family-centered, as I already explained. So it goes from disease to persons to families. That's, I think, the gradient. And it's not a strict separation, of course. I mean, this is all a gradual difference. It's not a hard difference, I think. So I think I'm coming to the end of this part on. It is the end, I think. There's no more slides. There's not even a conclusion. Well, that's a pity. No, so, well, maybe just to conclude, I hope I've been able to show a little bit about the values that are present in palliative care and how they are somewhat different, even though it's a gradual difference from other forms of care. And I think maybe as a last thing to mention, I always hope that other forms of other areas of care in the hospital and outside of the hospital can learn from palliative care in these, let's say, holistic and quality-oriented elements and aspects of palliative care. So that I think was, I'd like to end here. Temporarily.
Thank you very much, Prof. Dick. I think in order to make it more symposium-like,
yes,
we're going to switch the discussion from the back to the front, so that because you have another discussion later,
yes,
so or another topic, maybe we can give comments towards the information we just heard from Prof. Dick, especially about the differences between chronic, acute, and the palliative care, and how we see it in Indonesia. Where do we remember hearing the first time the term of palliative and how do we use it here. And then in the information that's shared by Prof. Dick, and then we can look through maybe what do we use here in Indonesia. I would like to perhaps ask the participant or audience, do we really use the palliative care in the term of language or history like what Prof. Dick explained before, or is it come naturally as the culture? Because in our culture, I think we are taught to look after the dying, the elderlies. It is part of our culture and our values. So even when before they are dying, we are, I think in our culture, we tend to provide their needs. But I would like to open to the participants, what do they think about this in our culture? As mentioned before regarding pain, the aim for palliative is to reduce pain, but often in our culture, I think in some culture and religion, the pain is taken as a test from God. So when we actually achieve and then go through the pain is a blessing. So it's like we are succeeding in the test. So perhaps Ibu Siwi or other participant would like to give some share or knowledge or comments about it. I know I've seen in Panti Rapi 2 years ago, sister, when I witnessed when you actually help to balm the body and then do the last rite, it was a very joyful moment, if I remember. That was less crying, I think. Do you remember when one of the sister died? One of the family of the sister died, and then you went through the process, and I happened so to finish my my research there, and then there were less crying. It's very serene, even though the patient has gone through perhaps some period of suffering due to the illness. Would you like to share a little bit, sister? Maybe a few sentences? Or others first? Okay. Yes, please. Shall I bring you the mic? Maybe you can introduce your name, where you come from, sir.
Thank you, Mrs. Moderator. Thank you, Prof. Dick. And I would like to also say my greetings to everyone here, my teachers, my seniors, those of you who are writing papers that I would really like to cite on my PhD thesis. Thank you very much for having me here. My question would be about the palliative phase, which is, as Dick has said, it was like the phase where the patient could not be prolonged anymore regarding their life. So it probably become a little bit challenging for the doctor to precisely predict, and then it may also become uncomfortable for the doctors to share what is their planning for the patients regarding perhaps the taboo on talking with death. So I am actually wondering how the doctors in the Netherlands or perhaps in the Europe is conquering this taboo and this uncomfortability in talking about this. Thank you.
Yes. Okay. Thank you. Thank you very much. It's true. I've shown you this image where palliative care started early and got more important all the time. I think at the beginning of that point, there is a way to realize for yourself as a doctor or as a nurse whether someone is beginning that palliative phase, and that's the thing that we call, and you have probably heard about it. It's the thing that we call the surprise question. I'm not sure, did any one of you hear about the surprise question? It is essentially the question that a doctor may ask himself or herself, asking, would I be surprised if this patient would die within a year? Because that apparently is quite a good indicator, not perfect, but it's quite a good indicator of whether a person is going to start the palliative phase. So if the answer is, I would not be surprised, so if the answer is no, then it would mean that could indicate the beginning of palliative care. And then as as you said, Bagas, it's still very difficult for doctors, also in the West, to start speaking about this, because they're still full in the curative mode, let's say. So what I think then is the conversation will have to be about what people think about their future. So you will, I don't think doctors then, obviously they will have a plan for the patient, but the first thing they need to do is inform themselves about what the patient finds important and what their wishes, and talk with the patient about how they look at their future and what kind of care they would want. And one of the questions that you might want to raise is if they realize that the disease may eventually lead to their death, and what they would want then, where they would want to have that, whether they would want to die in the hospital or want to die at home. And so it's a gradual process. But if you ask this surprise question, then you also have time for the process. It's not something that you have to do within a few days. And that's why I'm stressing so much the early elements of palliative care. Because otherwise you only have a few days left. So you have to be early, and then you have some time to gradually do that. So that's is that an answer to your question? Okay. Yes. Oh, Busiwi, and then, so I have two. Yeah, right.
That's good. It's get warmer and more lively.
Yeah, long discussions about who will be first.
Thank you very much, Prof. Dick, for a very inspiring, because we have to be very, it's different with the practice here, maybe, yeah.
Sure.
Especially, usually patients here seeing the pain as they try to cope with the pain that they have, because it's kind of, this is to, what you call it, mengurangi dosa, lessen to lessen of the sin. Yes.
To lessen of the
sin.
Lessen our sins.
Yes, right, okay, yeah.
That's the one.
Yes.
That's from the patient's perspective, but also for the family. Usually they will demand the doctor to prolong the life of the loved one, because of their, what you call it, they want to be mendem jero. Mikul dhuwur mendem jero. It means the respect. Yeah, in Japanese words, it is mikul dhuwur mendem jero, means if you want to bury it should be very, very deep, but if you want to hold, it should be very high. It means that you have to do, until you don't have anything, for instance, like that. So sometimes patients or families said that, please doctor, I will do everything, even though the cost will be very expensive, for instance, like that. So this is also, it comes with the educating patient, educating family also, I think. Yeah. So sometimes.
Yes, of course. No, I realize that, and I think many patients, to some extent, think that pain is necessary to really shouldn't. They should bear the pain. And that's we have that in the West, in our country as well. So there's quite a few people who do not want to have painkillers, or not very strong painkillers, and there's obviously other fears around morphine and that kind of painkillers also. So I think essentially, if that's the case, then a doctor will have to follow that wish and guide and support the patients as much as possible, even though the doctor had the feeling that he would like to treat the pain better, he still has to conform to the wishes of the patient. And I mean, that's really an essential element of palliative, the idea that you have to go on until you don't have anything left. And I think also many Dutch patients want doctors to do that. And that may sometimes lead to differences of opinion, but I think most often what you have to do what palliative, it may, if you go one or two further back, one back and then another back maybe. Well, if it does work. So that's so that it implies that you can do both palliative care and sometimes quite aggressive curative care, if that's what the patients and the families want. Yes. So I don't think it excludes each other. Yeah. Sure. So, other question maybe? Yeah.
Ja, goedemorgen.
Goedemorgen.
Professor Willems.
Hello.
I don't forget to ask a question.
Good.
So, nice explanation in regard to palliative care. So the definition is that should be enhancing the quality of life for a patient as well as the family caregiver when they are facing life-threatening illness. And you also mentioning about the initial approach of palliative care team as well. So it seems like when we are taking care of the patient, it feels like they are getting on the train and they may not getting off from the train. It feels like the last destination is the death. But how would you elaborate or explain the situation in which the illness is not threatening anymore? For example, in the case of cancer, breast cancer, she can survive. For example, she can follow the mastectomy, follow the chemotherapy, and she sort of, survive from that. Because I have the experience of some of my colleagues, she can survive almost 20 years from breast cancer. And in this kind of situation, how would you explain the role of palliative care? Should we then, release the palliative care intervention, or it still be there? How would you explain in this kind of situation?
That's a really good question, because well, I just saw the image. If we usually think of it as if the disease goes on, but obviously many people are cured from cancer. So the question is, should you start this palliative approach in the phase where there is still a possibility that a person may be completely cured? I think that's very good a very good question. I think the first thing is that be the moment where you think this patient may die within a year. I think if that's not the case, and usually when people still get cured of their cancer, you would not think that they may die within a year. So then I think the whole process should not start yet. It's only in the moment where you think this is a situation in which death has become very probable or even unavoidable that you would also start the palliative approach. So there's a long period where, and also many of the cancers in Europe and also here probably are getting chronic. It may survive and may even be there for decades, several times 10 years. That's not a period in which you start talking about palliative care. So palliative care is really linked to the situation in which you as a doctor or as a nurse think this might lead to death within the following year. So is that an answer to your question?
So that's the key is that to apply the surprise question itself before we get on the train. Right.
That's the key, I think. And then even then, it may occur that a patient, against all expectations, gets cured from the disease. And then I think you have to to go down and stop the treatment. And also the palliative approach is then not appropriate anymore.
Yeah.
Yeah.
Thank you.
Okay, you're welcome. Yes, Yati, here's a microphone.
Thank you very much for your exciting, important topics. When I was still active in my practice, I faced the journey.
It's a bit, I think it's a bit, you can have, yes, but...
When I was still active managing or having patients, here mostly are following the paternalistic, especially the Javanese.
Yes.
Parents don't want us to tell what's the truth to my patients. However, I always share with the patient. I try to know how far can he accept. We sometimes feel this moment.
Yes.
So, yeah, I try to invite the parents to tell their children, just helping.
Yes.
So, but sometimes didn't work.
Yes.
Do you have any suggestions? Thank you very much.
Yes, well, thank you for the question. I remember cases as a general practitioner when I was still working as a GP, same as you, when I was still treating patients. I remember one woman in my practice who was of Dutch descent. She had no, it wasn't someone from another country. And then she got angry with me. And she said, "What are you talking about? I'm not going to die. We are not going to speak about dying here." And then she turned away. And then I think for a week or two, she didn't even want to speak to me, even though we had a very good relationship before. And then her husband also said that she was really opposed against speaking about death. And I think that's a very difficult situation because you have the feeling that you cannot give the care that you would want to give and guide and support her also in the struggles with death. But if a patient doesn't want to speak about it, then you cannot force someone to do that. So in fact, what I did with this patient of mine, I've just kept silent about dying afterwards. So I just guided her as well as I could, and I treated her symptoms as well as I could, but we never spoke about death again. I did speak, but only I once mentioned it because I thought she already knew this for a long time. And then apparently she had, or she didn't want to, or she hadn't understood it. And I did speak with, it was a difficult situation because the husband wanted to speak about how her last weeks would be. But he also could speak with her about it. So it was a very difficult situation. So I had different contacts with the husband and with the wife. But with the wife, she finally died without speaking about death even once. And maybe that was a good way too then. For her, that was a good way. So I think at some point we have to accept that people don't want to speak about it. And that they just want to go on.
For the best of this.
Yes, I think so. Even though it was hard for me, and it was also hard for the husband.
Yeah.
But we still have to put the patient central then. Yes.
Yeah.
Yeah.
Thank you.
Thank you. There's a question apparently from the chat, or no?
Yes. So basically, the key is to put it on the patient's wish and desire,
Obviously.
and then above
Yes.
all.
Yes.
Then this is, I have one question from online. So because we have already 3 from the audience, then you mentioned the importance of catching it very early so that palliative care can begin at the earliest possible. This question from Stikas Maranatha Kupang, Ibu Evelyn, said that in Indonesia is very, the old age or the elderly are very
reluctant to talk about their health and to go to the doctor. The number one reason is being not want to give trouble to their family of children. This is also maybe part of the culture to keep it to themselves, to lessen the burden. So how can we encourage, as a doctor or the nurse, to encourage the elderly to speak up or to help their, to make concern or to do checkup regularly without thinking that it will burden their families?
Yes.
Thank you, Prof.
Yes. Oh, yes. But this is so recognizable. There's so many elderly people also actors. Yes, then I think it stops. That's their wish. That's the way it has to be then, I think.
At least they will be at peace themselves,
Yes.
even though that physically they might be suffering.
Yes.
Thank you,
I
Prof.
think so, yeah.
I think the other question, we will move it to the... yes, Prof. Rika? One last question.
Okay. Hello. Nice to see you again, Prof. Rika. Really nice. Yes.
You mentioned that also in the brochure, in the first slide, there is investing in palliative care, improving health for elderly. And also you mentioned about modern palliative care is combined care, research, and teaching. When I'm listening your lectures, your very precious lectures, I'm thinking about palliative care might be also part of personalized healthcare. And then also nowadays research on approaching using stem cell therapy is very much supporting improving for healthcare for elderly, also our education, because we are facing personalized healthcare, precision medicine, and of course this topic is very important. Thank you very much.
Thank you so much for the question. It's a rich question because it has very many aspects. I fully agree that that palliative care should maybe be the most personalized form of care there is, because it's so much focused on this particular person and his or her family. And I really expect contributions from biomedicine also in the treatment of symptoms in palliative care. So I think it's very possible and very probable also that we will investigate the personal sensitivity to certain treatments of drugs. And we already know that some people have that there are very big personal differences in the reaction of symptoms to treatments. So some people are very sensitive to the side effects of morphine, for instance. So for some people it's not a good idea to start giving them morphine because they will be so semi-comatose from morphine. And you could prevent that. So you could prevent the side effects of treatments by maybe doing a genetic test beforehand. So there's, I think, ample opportunity also for personalized biomedicine. But the interesting thing for me in palliative care is that it should be holistic personalization. So it should be on symptom treatment, but also on their personal values and wishes. So it combines both the social and the spiritual personalization with the medical personalization. And about preparing future doctors, I'm going to speak about medical education, I think, this afternoon. And this is really one of the subjects I'm going to address because, as you say, it's everywhere. All disciplines have something to do with, can have something to do with this. So just to tell you a little bit what I'm going to say there is...
Sometimes face a situation.
You can't just speak to the patient because then the parents will be at least angry with you because you have, and you need a good relationship with the parents. So, so I think that the only possibility is to try to, what I try to do, because I know that type of case as well, what I try to do is speak with the parents and explain to them why you think that their child already knows what's going on, and that it doesn't make any sense not to speak with the child. Because quite often the child is quite aware. They're smart. And they sometimes are smarter than their parents. Yeah. So they know what's going on. Yeah. So that's the approach I take. So I'm then talking with the parents to explain to them why we should also talk to the child. That's, I think, the only way you can use, because you can't go again. Thank you. Thank you. But it's very hard. Really hard. Yeah.
Thank you very much for Professor Dick and for all of the participants who has, yes. And thank you for all.
Kalau ada satu pertanyaan, apa sebenarnya bioetika itu? Bioetika itu berkembang dari waktu ke waktu. Yang tadinya etika menjadi biomedical ethics, oleh karena yang banyak menggunakan etika itu kedokteran, medical tadi. Namun demikian sebenarnya pada saat ini yang tidak etis itu tidak hanya kedokteran saja, bisa terjadi di hampir semua bidang ilmu. Sehingga dengan demikian dari biomedical ethics tadi berkembang menjadi bioetika, kemudian global bioethics, ya, dan yang terakhir yang kita kembangkan di sini apa yang kita sebut dengan the new sense of bioethics. Ini pun saya mengembangkan ini distimulasi oleh sekretaris UNESCO yang di Paris. Pertanyaannya, Narto, kamu punya Pancasila, tolong etika itu dikembangkan ini. The new sense of bioethics itu adalah satu studi dari transdisciplinary subject, biologi dan seterusnya, ya. Ada sekian. Respect for others itu ada artinya tersendiri, berkembang lagi. Beneficent, non-maleficent, yang kita tambahkan di situ adalah tidak hanya justice, tetapi it should be social justice for all. Itulah Pancasila.
Center for Bioethics and Medical Humanity atau CBMH merupakan bagian dari Fakultas Kedokteran, Kesehatan Masyarakat dan Keperawatan Universitas Gadjah Mada. Sebagai bagian dari perguruan tinggi ini, kami mengemban tanggung jawab untuk melaksanakan Tridharma perguruan tinggi. Kolaborasi nasional dan internasional merupakan kunci dalam melaksanakan Tridharma tersebut. Melalui kolaborasi ini pula, CBMH dapat bertransformasi menjadi sebuah pusat pengembangan ilmu bioetika dan humaniora kedokteran dan membidani lahirnya program Master Bioetika.
Oh, semangat. Bela kerja itu udah berangkat.
Saya Witjaksono, umur 45 tahun, asli warga Kampung Kricak Kidul. Saya selaku Ketua RW, selaku Ketua Paguyuban Kampung Kricak, dan selaku Ketua Relawan Kampung Kricak Kidul. Orang awam kalau sudah mendengar Kampung Kricak Kidul itu pasti akan tahu keburukan warga kami khususnya di Kampung Kricak Kidul. Karena di era tahun 80-an memang sebagian besar khususnya warga sini sudah dicap, yaitu gudangnya para gali, gudangnya para preman, gudangnya para copet, yang notabene kampung hitam atau backlist. Tetapi kami berusaha semaksimal mungkin dari kepengurusan biar Kampung Kricak Kidul itu menjadi lebih baik. Pripun kabare, Mbah? Siap napa, Mbah? Nggih, amin, Mbah. Lho, Mbah.
Nggih, monggo.
Kula nuwun Mak Mi, wonten Mas Bayu. Wah, iki kabare yu. Dah.
Iki apa-apa ngene.
Piye kabare iki?
Ngene iki kanane ya lagi kok ngene iki.
Iki ngene.
Kricak itu orangnya enak-enak. Orangnya tuh enggak ada yang intinya nek ade gotong royong bisa enggak kaku banget. Enggak seperti yang dilihat orang di luar. Kan luar orang lihat itu wah, Kricak wis wonge ngono kae kabeh kan gitu. Ya nek kowe wis mlebu dhewe ning kene dadi masyarakat kene ya kowe bakalane paham. Oh, jebul kok ngene iki lho Kricak. Ya mungkin masih ada sisi negatifnya, tapi kan kita juga tidak bisa menghilangkan sisi positifnya toh. Kita harus melihat secara keseluruhan.
Gendang pulih babai.
Dan bapak-bapak muda yang intine ayo kowe wani ora? Wani apa? Ya wani makamke. Saiki nek ade ora terjun. Mesake wargane dhewe. Ya nek wis sesuk keluargane dhewe kepiye? Aku ngomong ngono kuwi. Ya wis wani, ya akhirnya bisa dilatih itu. Sesama rebukan sama Pak Muji ya wis ya dibentuk. Jadi ya alhamdulillah. Akhirnya beberapa organisasi di Kricak itu gabung. Yuk bareng-bareng guyung-guyung varian Delta iki.
Nama saya Galuh, saya dokter umum di Rumah Sakit UGM. Untuk job desk saya di rumah sakit, saya kan jadi dokter umum, jadi tergantung kebutuhan. Kadang saya kerja di bagian IGD, instalasi gawat darurat, kadang di poliklinik ISPA, Yudhistira 2 ini untuk pasien-pasien COVID juga, dan juga kadang di bangsal. Kalau ditanya pengalaman selama pandemi, kalau di IGD suasana itu udah kayak ICU, bukan IGD lagi. Di poliklinik yang harusnya pasien bisa jalan, udah kayak IGD. Bangsal biasa itu udah kayak semuanya ICU. Dan pasien itu antri di depan rumah sakit itu sudah biasa. Ada bahkan suatu saat waktu saya jaga, pasien antri naik mobil, dibawa mobil atau motor atau mobil dengan lagi sudah tidak.
Kan kadang-kadang ono to sing posisi wong Covid ngene iki. Ora kabeh wong iki gelem nyerak. Sedangkan wong iki butuh perhatian. Alhamdulillah kuwi tengene pangerten. Waktu itu ambulan Delta merebak itu memang, tapi kan lazismu kan tidak cuma melayani di gereja saja. Lazismu itu di semua Tegalrejo, kadang-kadang ada panggilan di mana. Kan mereka kan juga capek, keterbatasan personil juga. Kita jaga ke puskesmas ya tadi mau, dateng lah ya kangenan loh. Sedangkan ya nek puskesmas ibaratnya bu ini butuh bantuan ini. Kono gelewat telepon, masih retine ngono. Akhirnya sing nangani wong iki terus piye? Bulan ini kita dapat waktu naiknya jumlah COVID-19 varian Delta. Akhirnya kita berembuk psikisku sing ora kuat. Saiki gawean wis upah banget. Makam wis dina kok. Sampai ping 2, ping 3 SOP ini kan harusnya 1 kali 1 hari pemakaman. Nek ngomong ke sini, wah jan bener-bener meh aja nganti meneh lah.
Setelah pandemi yang Delta dan di pertengahan Delta, saya tergabung dengan tim pengabdian masyarakat dari Fakultas Kedokteran. Di situ saya merefleksikan diri bahwa kita semua ternyata berjuang di masa pandemi ini. Tidak hanya saya dengan teman-teman saya di rumah sakit, tapi semua orang juga merasakan perjuangan itu. Mereka juga sedih ya bareng-bareng, berjuang ya bareng-bareng. Bagaimana mereka bisa survive di pandemi ini dengan supporting system mereka.
Siap. Jos. Pripun Pak RT? Oh siap Pak RT. Jos.
Karena saya melihat bagaimana orang-orang relawan-relawan di daerah Ricak itu yang bahkan bisa jadi tidak dibayar, tapi dengan ikhlasnya membantu sesama. Itu sangat mulia sekali. Dan mereka juga berjasa banyak dalam menolong orang-orang. Untuk mungkin membantu membawanya ke rumah sakit. Kalau tidak di rumah sakit, bagaimana tetap survive tapi di rumah dengan logistik yang ada, dengan vitamin yang ada, dengan pantauan kesehatan yang ada. Mereka hebat. Itu sesuatu yang besar. Ketika pemerintah tidak bisa mengcover semuanya dan mereka dengan mandirinya hadir dan melakukannya, itu sesuatu yang besar dan saya bangga dengan mereka. Dan bisa jadi rasa keikhlasan, gotong royong itu yang membuat kita survive bersama.
All right. I'm going to give back the session to the moderator, Bu Puri.
Welcome back again to the room after a happy coffee and snacks. So we're going to come and start a program at Redmond University in Netherlands with dissertation entitled The Quality of Palliative Care for Patients with Cancer in Indonesia. So she's very fit to give some knowledge and insight because her specialty is in palliative care. Her research interests including palliative care, end-of-life, cancer care, patient care, quality of life, quality of care, quality of indicators, wound care management, long-term care, and also care for family caregiver. She is also a committee member of Indonesia Palliative Society and also a member of International Association of Hospice and Palliative Care in Asia Pacific. Several projects regarding palliative care has been completed by her. Among them is Good Nurse and Better Nursing in Palliative Care for people with Parkinson's disease, Perspective of Family Caregiver Indonesia, and Auckland Spark Project. For Ibu Christantie, would you like to come at front, please? The floor is yours, Ibu.
Yeah. Thank you, Ibu Puri. Good morning, everyone. Hello, good morning, everyone. Okay, yeah. Good morning, Prof. Sunarto. Good morning banget. Sugeng rawuh, Prof. Sunarto. Terima kasih, Bu Siwi. Yeah, it is an honor for me to be here and to have an opportunity to share about palliative care perspective from nursing and other professional caregiver in Indonesia. I would like to start my presentation with a brief story about my PhD journey. As also mentioned by Martina Sinta, she graduated from Radboud. I also graduated from Radboud, and my PhD project continued by Martina Sinta. So we are a partner until now in palliative care. Okay, at the first time I started my PhD, there is a very limited reference, very limited evidence in palliative care. So I have to switch my topic, and then I have to start my PhD with a very basic research about problem and need in patient with terminal illness. Now, a day when Ibu Siwi said, "Oh, Christantie, can you share about perspective palliative care from nursing and healthcare provider?" And I said, "Oops, I have to check in the reference." Wow, a lot of references now, a lot of evidence now in Indonesia about palliative care, and I found 100 articles that have an evidence about palliative care and the perspective of healthcare provider in providing palliative care. So we will see what the nurses say about palliative care and other also doctor and other professional caregiver. Oops. Okay. Yeah. This is the outline of my presentation. Hopefully I can meet the time. Okay, and yeah. Palliative care is not a new issue in Indonesia. I think Indonesia and also Netherlands have the similar years started the palliative care, but little bit different in the journey of palliative care in Indonesia and in the Netherlands. I think many factors influence the differences in palliative implementation. In 2007, palliative care policy was launched by Indonesian Ministry of Health. This is the only one regulatory in Indonesia to conduct palliative care. So we still waiting for the revise of this degree. Okay. Have a research about palliative care, and I think Dr. Maria Witjaksono will also as a speaker this afternoon. She have evidence about it, and we take a look. If we take a look of this breast cancer, it is a common situation. There's many cases like this in Indonesia. When I show this, help me please. Next, yeah. Nah, palliative care is humanitarian needs. Ideally, palliative care accessible for everyone who needs it, because with palliative care, the person who need the support with the life-threatening illness, they can get biopsychosocial, socio-spiritual aspect in caring, and then hopefully they can get the quality of life better, and also when the time is come, end of life care can be performed to the patient to get the quality of death. Prof. Sunarto, I remember Prof. Sunarto said that, the patient should have happy dying. Yeah, Prof, happy dying to get the quality of death. And in Indonesia, patients with who need palliative care, it is mainly in the hospital setting. That's why I think we in the integrated palliative care implementation, because of many factors, yeah, collaboration between professional, I think is also challenging in Indonesia. And regarding the definition of palliative care, I think WHO have many definitions. What mentioned by Professor Dick, I think 2002, yeah, the definition, yeah, and this is the definition in 2020, that earlier identification, correct assessment, and treatment of pain and other problem, it's very important to conduct, because without early identification, so if we connect with the discussion with Sinta and Prof. Dick, then since the beginning, early identification is very important, and then correct assessment also, I think also is very crucial to implement. Okay. Oh, what? Yeah. Okay. Then in Indonesia, because of so that's why it is still struggling with the knowledge of healthcare provider in Indonesia about palliative care. But I think the basic concept is understood by many. So today I think with this symposium, hopefully more and more health and about palliative care, and it will be beneficial for the patient and the family. Psychosomatic medical doctor have a important role in the provision of palliative care. They are training. They have trained the communication skill to deal with the patient, and this is also the paper from the psychosomatic medical doctor. We can read detail about the role of the psychosomatic doctor. Okay, how about the readiness of nurses in providing palliative care in Indonesia? I think in the provider, especially the physician who have the patient. Yeah, I can say here DPJP, dokter penanggung jawab pasien. Yeah, okay, it is very important. Now I found a study conducted in Bali with 375 nurses. It's about knowledge of nurses, and here we can see many questions. They say they know better, but some still don't understand. So then the item here, many islands are not easy to reach the place who have palliative services, and lack of information is also a barrier to access palliative care. They don't understand. Even in, for example, in Sarjito Hospital, they have installation for palliative care. If the patient and the family don't know about the information, then the ward should be empty because no one want to be a patient in that ward. It's also cultural aspect involved in accessibility of care and lack of socialization. Palliative care services are more often located. The term palliative care, okay, yeah. So it will be better for the patient and the family using the term, the word supportive care. And also still accessibility of palliative care have a challenge where a physician reluctant to refer to the palliative care due to lack of understanding, and also experience dilemmas because this is my patient for a long time. If I have to send the patient to the palliative care, then I don't have the right anymore to taking care of the patient, and healthcare providers should plan the comprehensive care and should work in interdisciplinary team using the integration of care. And I think it is also beneficial for the doctor and the healthcare provider in the hospital and also the community, because they can have the same standard whether this patient need palliative care or not. And also indicator for referral to palliative care is also crucial. Next, please. Yeah, this is the example for the model to taking care patient with the holistic in palliative care. Communication is the important aspect in this model. Next. Talk about continuity of care. After patient have hospitalized, then they need continue of care. If the community not ready yet, in the community service is not ready yet, then it will be the problem. When the patients stay at home, then they will go to the hospital, go to the emergency room, because the family don't understand how to primary care of palliative primary care can be used to ensure the continuity of palliative care after discharge from the hospital. I think it is very important. Next. Yeah, this is one of my study about the experience of family caregiver of children with cancer while receiving home-based pediatric palliative care in Indonesia. So after patient have the hospitalized and discharged from the hospital, then with the help of the NGO, they can get the primary, the home-based pediatric palliative care as a primary care in the community setting, so they can get the benefit from this service. And the family can get the support from, if they already 80, then people say, oh, that is a bonus, a lot of bonus for the person who can get 80 years old. But it is not true. I think when the family have to lose the family member, even in elderly years, more than 80, maybe also approaching 90, it is still sadness even. So that's why no more approach could include intervention for agitation, because elderly people is special. They also common suffer from constipation and also other symptom taking care. Health professional, especially nurse, should be correct assess the elderly, and also with the family solve all the problem faced by the elderly. Okay, and next. So, in my imagination, elderly has a right to have a good quality of life and to be happy. This is the modern elderly, so she combine between the modern thing, yeah, IT, and the conventional thing. Okay, next. The key message to convey about palliative care: help provide the best possible quality of life, help to manage pain, other symptoms, and stress of illness. It is a partnership between patient, family, and healthcare provider. Provide the patient and family an extra layer of support. Is appropriate at any age and any stage of a serious illness alongside curative treatment. Next. This is also important that we suggest coordination between hospital and primary care and the community to have a connection and link to solve the problem of the patient, and this can be also Indonesian healthcare system improve to conduct palliative.
Palliative care in the Netherlands has been organized over the last couple of years, and what we're doing actually now. So, and I'll try to stick to the 20 minutes because that's really a hard line. I understand that. Okay, so the next slide, please, because while you were talking, you said we had almost the same time of beginning. Yes. I think you were earlier, because, yeah, you know, yeah, you said 1992. I think we started in 1995. Yes, and we obviously, what's different also is that in the Netherlands, discussions about end-of-life care started with discussions about euthanasia. So the discussion about euthanasia is a lot older than the discussion about palliative care. And that I think is a historical mistake, because in fact you have to start by talking about the care and then maybe start about euthanasia, but you don't even have to. So we had the first large palliative care program launched by the Dutch government in 1995. They then started to subsidize 5 centers for the development of palliative care, and I've been the coordinator of one of those centers in the VU Medical Center in Amsterdam. So that was a program for 5 years, and it ended at around 2000, 5 years, and it had a subsidy, a total amount, which was quite considerable, of I think 50 million euros. So 50 million euros, which is, I can't say how much that is in rupiahs, but Bagas, you can, of course. How much is that? Non-acute causes. And I think we're seeing a development now in palliative care where there's more and more attention for the non-cancer diseases. So, and that goes from cancer to neurological diseases, but also psychiatry, for instance. So there's even palliative care development now going on in psychiatry where people, for instance, with incurable psychotic diseases or incurable depressions are also receiving a form of palliative care, which is different from the palliative care in other diseases. So we're really trying to expand it to other diseases than cancer. Can I have the next slide, please? Yes. So a little bit of organization, about the organization. Palliative care in the Netherlands is really integrated in the existing healthcare system. It has separate organizations. It's everywhere in the hospitals, a bit like Rika said already, it's everywhere. Like in teaching, it has to be everywhere. It is also everywhere in the care organization. And it's seen in the Netherlands very much as part of generalist care. So we feel that every single doctor, in whatever specialty he or she is working, needs to have at least a basic knowledge of palliative care, because they may be confronted with patients who are going to die. So it's really for everybody. But I think the focus in the Dutch healthcare system is on the general practitioner. And I've been working as a general practitioner, and I've had quite many patients at home to care for who died eventually from the disease that they had. So I think most palliative care is taking place in the home, even though many people die in the hospital, but that may just be the last couple of days. So then the care has been at the home, but at the end they go to the hospital. So I highlighted one thing which is special for Holland when compared to other European countries. And in Holland the decision has been taken by the medical professional organizations and also the government that there would not be a specialty called palliative care among doctors. So there's not, strictly speaking, a palliative care medicine like there is neurology or oncology or whatever, or ENT or whatever you have. So there's not a palliative care specialism. In England, for instance, there is a specialty like that. So it's a recognized specialty with a 5-year training. And that is because in the Netherlands we really attach a lot of attention to the fact that it should be generalized, generalist care. So it should be part of normal healthcare. But there are people who say we need specialists, but we do have experts. So I've been in a training program that trained expert GPs. So those are GPs who have a lot of extra training in palliative care. I may be speaking about that a bit this afternoon. And we have regional networks. They're in those regions that I showed to you. Here we have networks of care facilities, consultation teams. And I think what's very important too, and that has been a struggle a little bit in the Netherlands, is that palliative care is regularly reimbursed by the National Health Insurance. So people don't have to pay for palliative care extra. It's all part of the National Health Insurance. But that took some time to have that organized. So that's what I wanted to say about the organization, the way the things are set up in the Netherlands. Can I have the next, please? Now this is quite so you may skip this one. That's not. So I just like to give it a bit of a feeling, give you an example of a patient that I cared for in my general practice. He was a man of 63 years old, and he had amyotrophic lateral sclerosis. So he didn't have cancer. He was suffering from a severe neurological disease. I don't know if you all know about this disease, but it's a very severe degenerative neurological disease where you have increasing paralysis and may end up needing oxygen or even artificial respiration. So it's a really, really very serious disease, and it's usually quite many things that he did before. And one of the characteristics of the disease is that people remain very sharp. So they don't lose their cognitive possibilities. It's only the muscles and the paralysis. So he remained very sharp, a bit too sharp sometimes. He was a very nice but very sharp person. And he lived independently in their home with a spouse, and they had 3 children, adult children, who were living nearby in the same village where I was working as a family physician. And they had one daughter with quite severe, one of the 3 had quite severe psychiatric problems, so that added a bit to the concern and the worries of the father also. So at some point, and that happens very often in ALS, he got trouble swallowing. So he got a PEG catheter that goes directly to the stomach. You may have heard about that kind of treatment. And so he was fed directly through the catheter of about a year. And then at some point there was a very difficult, we went together through a very difficult period in which he had some form of change of character. He's always been a very sharp man, but friendly. And now he got very unfriendly with everybody, except with the doctor, which I felt was a bit strange. Why wasn't he angry with me? Because I couldn't help him really. I could support him, but somehow he kept he looked up to doctors, so he wasn't angry with me. But for his wife and his children, that was a very difficult period. So they have needed a lot of psychological support that we could organize within the home care team. So there was a lot of talking. After the diagnosis, he died peacefully within the family. At one point, I didn't mention that in the slides, at one point there was a discussion about artificial respiration at home, which we can have, and I think it's also sometimes possible in Indonesia. But then that was something he was very clear about. He didn't want that. So he declined the offer of artificial respiration at home, which could have prolonged his life to some extent. But he said, then I will not be able to speak anymore. Because he would need a device, so he would not be able to speak anymore. And for him, communication with his family at the time was so important that he declined that treatment. And I think it was a decision that fitted well within the way he lived. So I could really understand that he didn't want that. So this is just to give you an example about how in home care and general practice we can deal with palliative care. Can I have the next, please? Can I have the next? Yes. So I'd like to also, because of the 20 minutes, I'd like to skip this one as well. Can you go on with the next one? So as I said, one part of the organization of palliative care in the Netherlands is the existence of consultation teams. And I think that's a very good development that might also be useful in other countries. I know that they exist in England as well, but they might also be maybe interesting in Indonesia. And then there's a larger team behind that consultation. So the core team can consult with medical specialists if there's a reason for that. So if, for instance, there's pain that's very difficult to mention, there is an anesthesiologist in the larger team. So the GP and the team may then consult the anesthesiologist in the larger team. And this is usually, I mean, telephone is very old-fashioned, of course. We may do that by phone, but it's very often also WhatsApp and email, even though it has to be safe, of course, but well, anyway. But they also do outreaching work, so they're even available to go to the home of the patient. If it's a really complicated case, then the consultation team will go to the home of the patient if the patient is at home or to the hospital and see the patient for themselves. So it's not only phone or WhatsApp or email consultation, but also outreaching. Can I have the next, please? One point I'd like to say something about is where people die in the Netherlands. And we know that very well for patients with cancer. About 2/3 of the patients with cancer eventually die at home. And I think that's quite a high percentage, even though it is lower than what patients would want. I'll show that in the next slide. And 28 of them die in hospital, and 7%, so those lower percentages in homes for the elderly, and just 1% in hospices. So we have a system of hospices in the Netherlands, but finally they have very good care, usually excellent care, but in fact it's not used by many patients. It's only maybe the more complicated patients who finally die in hospice. So quite a large proportion die at home. Can I have the next, please? A little bit, because we're in palliative care, we're doing that since about the same time as you started doing it, and we still have some issues that we think need to be solved in palliative care in the Netherlands, so that need development. So, as I said, insufficient communications. You also mentioned that, I think. Insufficient communication between hospital and primary care. Can I have problems with advanced care planning? It is increasing. People are talking about care in the future more, but it's still insufficient. And I think the availability of spiritual care, especially in the home situation, needs further development. And the last point I'd like to mention is that we have some underserved groups. Yesterday I was at a PhD ceremony which had researched palliative care for homeless people. Like in the big cities where we have quite a lot of homeless people, palliative care for these people is underdeveloped, and it sets particular demands because of their homeless situation. So these are a few things that are still in development and that we still need to solve in our system of palliative care. Then there's one last thing that I'd like to speak about for about 2 or 3 minutes. Could you give the next one, please? So because there's still quite a lot to be done, there's been an initiative from all healthcare workers involved to set up a framework of quality standards for palliative care. And I think this is a crucial development, that we have been able to specify what good quality of care is. These are the core values. I'm not going to quite, they're quite similar to the WHO description, but just described a little bit different. I won't mention all of them. You get the presentation, you can look at them if you want. Can I have maybe the last one, I hope? The next one, please. No, the next. And the next. And, oh, that was the end. All right, so, okay. So I think, if by way of a conclusion, I think we're in a comparatively short time, because it's like 30 years, which is not very long. I think both countries have succeeded in developing quite a lot in palliative care, and I think both countries are also still facing quite a lot of obstacles and problems. And I personally feel that the
question from through Zoom. Maybe I read it out. This question is for Prof. Dick and Ibu Christantie, and then there will be some more coming. The first question is for Ibu Christantie. Since they both in Netherlands and then both in Indonesia, palliative care team is a multidisciplinary team. If I am a physiotherapist in a hospital, how can I take an active role or active part in a palliative care? That's the first question. And the second question from the same person, Pak Wibowo, is palliative care in Indonesia is covered by the national insurance BPJS. In Netherlands, Prof. Dick mentioned is fully covered. So that's the two questions, Ibu.
Ya, thank you. Jawabnya pakai bahasa Indonesia aja.
Alright.
Yang
Yes.
nanya orang bahasa Indonesia.
Ya.
Memungkinkan untuk fisioterapis menjadi bagian dari tim perawatan paliatif, ya. Terutama karena pasien ini mungkin dengan serious illness, mereka memang bila dia statusnya datang ke rumah sakit untuk perawatan paliatif. Tapi kalau datang ke rumah sakit sesuai dengan penyakit yang diderita, misalnya dia CA atau
point, because many patients in palliative care, especially elderly, have many drugs at the same time. So I think in most palliative care teams in the Netherlands, a pharmacist is represented, especially because of all the interactions and all the possible problems. And also for something else. It's also the case that many patients keep using the drugs that they already had, that they've always had, and it's not always necessary. So sometimes it's not very useful to go on using antihypertensive drugs, for instance. If you're in the last few weeks of your life, that's not very useful. And it may be burdensome and sometimes dangerous. So the role of the pharmacist very often is also to cut drugs that are not useful anymore.
During
so it's a
the
really
last
important
weeks,
point. Yes. So to sanitize the whole, because these people sometimes come in with bags full of drugs that they use every day. And that only adds to the suffering, and it doesn't help.
So there is an important role for the pharmacist. Then the next question is also from online, from the Zoom, for Prof. Dick, is how is the Western perspective see the Indonesian law permitting us to withdraw all the supporting care in palliative care to the clinical's evidence and informed consent approved by the family instead of the patients who are actually supposed to sign? Because in Indonesia, there is very often the family take over and then decide on behalf of the patient, even though the patient is still capable of making decision.
Well, I think that, does it still work? Yes. I think that happens less in the West. I think that usually the family will not take over the decision as long as the patient is still capable of doing it. Even though they can be very involved. It can also be a way of caring for someone that he doesn't have to take all these difficult decisions. But still the patient will be involved in every important decision, I think. And we don't usually work with with signatures very much, not too much if it's not necessary. So if it's well documented and the decision is taken, for instance, to withdraw a treatment, so to stop certain, like I said, to stop certain drugs that are not useful anymore, then if it's well documented in the patient file, then you don't need signatures from patients or families to do that. So that's we try to avoid making it too legal and too complicated and with signatures and everything. So that's the way we deal with it, I think. Yeah.
What about in Indonesia, Ibu Christantie? Do you face the same issue?
Yeah, in Indonesia, because the autonomy is not in the patient himself, yeah, but it is a family issue. So it is very often that the patient even don't understand what happened to their own body. That's because of the culture, I think. Yeah, but Indonesian patient say that that because the patient believe that the family is the one who
the rightful
responsible
one.
for the patient. So even as like what I give the example, even the patient with the breast cancer have to to make a decision whether she will go with the chemo or not. Then she said, "It is not my decision. It is my husband's decision."
That's very nice. We do have that sometimes. That patients say, "Why do you ask me? It's not my." No, well, they will say I'm already ill, and why do I have to think about all these difficult things? My husband knows me very well, and he knows what I want. So patients sometimes will refer the decision to their family, and that's also part maybe of a cultural issue, but it may also have to do with the fact that people are just too ill to bother with all kinds of decisions.
That's true. Yeah. Okay. Thank you, Prof. Dick and Ibu Tanti. Yes, Prof, may I finish one more from the Zoom? This is the last one because I'm sure the Zoom line is waiting. Thank you, Prof. And one last question from the Zoom is they said, Prof. Dick, this one is actually from the last question from the last presentation. This person, Pak Benny, is asking, on your presentation is mentioned palliative care can be used as a prevention. He wasn't very clear. Thank you.
Yeah, thank you very much for the question, because I often, that leads to confusion sometimes. What I mean is that palliative care can try to prevent severe symptoms from occurring by being very early. So, for instance, what sometimes happens is that people with a lung carcinoma, they may have a severe bleeding. And then in order to prevent that from happening, you may already treat the veins beforehand by radiotherapy in order to prevent the symptoms from coming. So that's the kind of prevention I'm talking about. It's really prevention of suffering that's not really necessary, so that could be better to be early in that and to prevent it than to relieve it.
Thank you for the answer, Prof. Dick. Prof. Yati, yes?
Organized by, located at the home of the headmakers, who serve comprehensively about several prominent problems. I think that is Posyandu. And I would like to ask you,
Christantie, Prof.
Have you ever thought about utilizing this Posyandu, who is available in almost all parts of the country, especially in the place where far from the health services?
Yeah.
This is for you,
Yeah.
Christantie, and later for Pak.
Yeah. Okay. Thank you for the question, Prof. Yati. I think say that we, the palliative team in nursing school department, already have the pengabdian masyarakat, and we train the cadre to serve the family, to teach the family how to taking care the patient when the patient stay at home. So we have a training for the cadre to about home-based palliative care. So already how many area? Five? Yeah, in Sleman, still in Sleman.
Oh, in plan.
Yeah.
So if it is
No, it's already 5 areas, and then we will continue with another place. So hopefully it will be more cadre understand how to deal with the problem with the illness patient at home.
I have a suggestion, if it is possible. We all have in all places, especially which is far from the health system.
Yeah.
We call it posyandu.
Yeah.
Integrated post.
Yeah.
Placed at the and supervised and served by the village themselves.
Yeah.
What do you think about using that system? Because the system is already available. Do you have any idea, or have you ever thought about it?
Yeah.
If you haven't thought about it, I have a suggestion, because we have a very good, successful program utilizing posyandu for the health and children. So this is my suggestion.
Yeah, I think, thank you for your suggestion.
Well, we don't maybe have that type of system, but I think it's very important to use the resources that are available in a village, or to spread that kind of thing. So we try to do that, to use the community resources. There was one other point that you mentioned a few times that I think is really important to realize, is that it's very important to teach the families how to deal with symptoms. Because we have the families to deal with threatening symptoms is one of the elements. And I think that's really to prevent inappropriate emergency room visits and all kinds of things that happen to, because it's very difficult for families to deal with that kind of threatening symptoms. So they really have to know that it's no use, and they also have to prevent that. I have no time. I had an example of something like that which
Go
occurred.
ahead, Prof. I think that's a good example. Maybe it can be implemented here.
It's just the example where I had a patient once in my practice who had a throat cancer. She was a woman who had smoked. Well, it was due to smoking, of course, and she had a throat cancer, and we knew that it was a very risky place where she had it. So it might lead to what they call a blowout. That must be known to some of you, which is a lesion of the carotid artery that goes into the throat. So it gives a lot of blood, and it's terrible for the family to see. So this patient was at home, and she was, in fact, in the last few days of her life, and her husband was taking care of her and the children too in a perfect way. It was so good to see. And then one night, and I think it was very good, a nurse said to us, if there's a risk of this occurring, then you don't want her to go to the emergency room, because she will not even make it. It's usually a few minutes. And having her in an ambulance would only add suffering for everybody. So the nurse said, you have to speak about this with the family, and that's what she did. And she also said, and I found that maybe the best thing that I've ever heard, she said you should replace the white sheets that she has with red ones. Because people get so scared of all the blood on the white sheets. And if they have red ones, it's a lot more quiet. And she had learned that from a palliative care team, I think in England. So that's the way, and it happened. So one night she had this lesion in the blood came out, and she could remain home because the family was well prepared for the symptom. And I was so happy that...
Thank you very much.
Important part of care, and who don't think of it as a sort of a leftover care where people go, but they who think it's maybe the core of our work as professional caregivers to help people in the last weeks or months of their lives. So a group of motivated people is really crucial.
Thank you, Prof. Dick. Thank you, Prof. Yati. So that we are all clear about the aim of the palliative care, and also what is going further is at the end the last train is dead. So, but we have to make it as comfortable as possible, and if possible, train is dead. So, but we have to make it as comfortable as possible, and if possible, to have a beautiful dying or a good dying. So with this, I would like to give 5 minutes to sister to conclude, because she will be giving an input and then talk about how is the beautiful dying. We're talking about the caring part before. Now we're going to give her 5 minutes to explain about the beautiful dying.
Thank you, Mbak Uri. Very much. I would like to express our gratitude that we, Pantirapi, able to come here to have an invitation. And dying in the dignity is part of the palliative care. Then I really say yes in the explanation of both of you at the end, that the palliative care is not only for the cancer, but also for a chronic disease, or sometimes situation that they suddenly acute, that unable to it like this, and also the nurses. Yet nurse must be really sufficient knowledge about the palliative care, but also the holistic approach of really the science core, the nurses. But it's part of, and then the psychos, whatever the disease is. It is for cancer, for the chronic, but yet every single person have this aspect for the spiritual and psychological aspect. We need to listen about palliative care as the physician, the doctor. So just my dream that this concept of palliative care able to put under the curriculum of the doctor. Even the Dr. Umum, the general doctor. So, thank you.
Thank you. Sister Josephine is the Director of Nursing from Pantirapi. Thank you, Sister. With that closing information or sharing, I would like to give back the time to the MC to conclude the first session. Thank you.
Thank you very much, Bu Puri, for carrying the discussion and moderating the first session. Now we have concluded the first session of today's symposium, and we're going to have a lunch break and prayer break. So we'll see you again in 1:15 p.m. Yogyakarta time. And please enjoy your lunch, and you may do your prayer for Muslims. And for online participants, please stay tuned to the chat room on Zoom so you can get informations, and also please don't forget to fill out the registration form. Thank you very much for your kind attention.
kita Bu, tesis kita. Ya kan, iya mau ngomongin det nanti kalau gini waktunya ya. Oh ini aja kayak ginian ini kan pekerjaan yang di luar rencana, ngerti-ngerti. Kapan-kapan kita bikin workshop kematian yuk. Tapi workshop kematiannya warnanya rame-rame pakai balon, biar orang tuh masuk ke situ. Oh kematian kayak gitu. Yuk. Pengen kayak gitu. Aku juga orang itu tidak memandang kematian sebagai sesuatu yang mengerikan. Sambil sambil fokus grupmu nih. Iya, yuk. Kalau masuk balon-balon gitu kan pasti orang tuh. Ayo.
Ini yang pertanyaan Pak sama kita apa?
Tes. Dokter Tiwi.
Tes. Ladies and gentlemen, please take a seat because we are going to start our second session soon. Distinguished guests, ladies and gentlemen, welcome back. We are back again in Palliative Care Symposium, Investing in Palliative Care, Improving Health for Elderly. Symposium held by Center for Bioethics and Medical Humanities and UNESCO Chair on Bioethics Universitas Gadjah Mada in collaboration with Amsterdam University of Medical Centers. Now we are entering the second session of this symposium today, Educating Palliative Care, and I'd like to welcome this session's moderator, Dr. Gigi Agnes Bakti Pratiwi, Master of Public Health. Dr. Tiwi, you may take the stage.
Thank you, Mbak Tia. Please allow me to moderate this session. And we would like to thank the participants in this studio and also online for being with us in this afternoon session. Thank you also Dr. Maria for being present through Zoom with us. So let me introduce our first speaker for this session, Dr. Maria Astheria NL Witjaksono, MPALLC FU. She is palliative care physician at the Department of Palliative Care, Dharmais National Hospital, National Cancer Center, Jakarta, Indonesia. Dr. Maria is also guest lecturer at Faculty of Medicine, Universitas Atmajaya, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, and Faculty of Medicine, Santo Carolus. Dr. Maria completed her master in palliative care, focusing on palliative care physician at Flinders University, Australia. She also completed her doctor in medicine and health at the Faculty of Medicine, Universitas Gadjah Mada. She is active at Indonesian Palliative Society as head of foreign affairs. Dr. Maria is also member of Asia Pacific Hospice and Palliative Care Network for Indonesia, Asia Pacific Primary Palliative Care Group, and International Association for Hospice and Palliative Care. Welcome, Dr. Maria, and floor is yours.
Thank you, Ibu Putri, for a kind introduction. Excellencies, distinguished seniors, particularly Prof. Tati, Prof. Yati, Prof. Narto, and Prof. Mubarika, are they still there? And distinguished speakers, particularly Professor Willems. Colleagues, ladies and gentlemen, good afternoon. It's such a great pleasure and an honor for me to have the opportunity to share with you about Indonesian perspective on palliative care education in this scientific meeting. I do apologize that I'm not able to attend offline due to an important medical appointment that I need to fill this afternoon. Please let me share my my PowerPoint. In the countries where I studied, also because in the countries where I studied, also because, of course, based on my studies, the discussion that happening with colleagues recently and with the communities, but also few studies that have been done in Indonesia, including Ibu Tanti's and Ibu Sinta's study in palliative care. So first of all, I'd like to thank the organizing committee for the invitation, and I declare that there is no conflict of interest to disclose in this presentation. This is the outline that I will present today, and it is always in palliative care teaching or with the case of a patient, of a cancer patient, to give us an overview about the experience and the needs of the patient with advanced diseases who are approaching the end of life and facing a myriad issues that hopefully bring us some ideas about what, who, when, where, and how education on palliative care need to be delivered. Mrs. X was a 40-year-old lady diagnosed with terminally stage of breast cancer metastasized to bone, lung, and liver. She was a single parent of a 17-year-old daughter since her husband died for a car accident when she was expecting the baby. The patient was consulted to palliative care for an intractable pain related to the infected fungating wound, multiple bone metastasis, and lymphedema. Challenged with her questions: who will pay my bill? This apartment has not been paid for 6 months. How will my daughter's life be when I die? I'm tired. Distinguished colleagues, an incurable disease impacts the family's life enormously. Her teenage daughter was reported becoming irritable, uncomfortable to stay at home. She enjoyed party and movies more. She frequently absent from school and not doing her tasks, which brought her to be grounded. All that complex problem was never taught to our students as an individual experience that needs patient and family-centered approach to relieve their suffering comprehensively. That to add life in her days may be much more important than to add days in her life. WHO considered palliative care as the most appropriate service for patients with an advanced life-threatening disease. It is the art or science of providing relief from illnesses-related suffering by paying the bill of rights to have the best treatment until the patient's end of life. Right to be treated as a living human being until die. Overcome the challenges of the development of palliative care around the country. Education is one of the essential factors in palliative care development. Besides the government policy and its commitment, professional awareness and willingness to provide palliative care, drug availability, and community participation. We found many barriers in the development of palliative care in Indonesia that has been stated by Ibu Tanti. Our failure to engage education sector is one of the major hindrances. Dissemination of the principles of palliative through various methods so far is increasingly accepted by healthcare professionals and the community. However, palliative care training for professionals is limited. Let us look at the epidemiology report. These are the diseases with highest mortality and cost, and this is the government funds for these catastrophic diseases in 2019. When we focus on cancer, for example, looking at the increasing incidence, prevalence, and mortality rate, as well as the significant palliative care principles to affirm life and regards dying as a normal process and important. The barrier of the developing palliative care in Indonesia, that we have lack of training and education and absence of accreditation of the existing courses. Basic model of palliative care is the only training model accredited by Board for Development and Empowerment of Human Resources. Those who pass the post test will have a certificate of attendance only. So far, we also adopt the SIF, this is Singapore International Funding Model, to use in our palliative care training. In Indonesia, it is a challenge to engage the medical world. Palliative care has no official recognition status, so there is great reluctance among physicians to commit their time for training in a field that does not provide the potential for career development. In my observation, palliative care is more acceptable in nursing education. This is the current education palliative care in Indonesia. Unfortunately, I don't have any exact number, but in in undergraduate program, palliative care has become a core module in nursing curriculum in some faculty of nursing. Also in medicine, it can be an elective or core modules. Palliative medicine as a medical specialty followed by Australia. Yeah, in the concept of good death. Early involvement of palliative care is more beneficial, not only to patient and the family, but also to the referring team to achieve the goal of their treatment and involve them in an adequate interdisciplinary team. Palliative care professionals should be conducted with culturally sensitive manner. To help this patient continue living his remaining life and contributing to his family to the fullest extent possible and for the longest time possible, and preparing his wife to take over his role after he died. And this culture is needed by palliative care professionals in carrying out this task. What makes palliative care team special is that the patient and family are central members of palliative care team. The team share common team goals and work interdependently in planning, problem solving, decision making, and implementing, as well as evaluating team-related tasks. It is different from a multidisciplinary team, which commonly applied recently, that in interdisciplinary team, members function interdependently and team identity displays personal identity. So it is like in this orchestra, its members should play his or her specific instrument with the same basic tone. They need to listen to each other. They know when to start and to stop their part since the beginning to the end of the song, so they can perform a harmonious melody. And this patient is part of the team. The classical communication pattern in Indonesia and that the communal pattern in decision making should be taught. This is what I refer is religiosity which live in Indonesian community. Basically, what to learn through palliative care education is what stated in its definition and what are covered in the principles of palliative care, which has been discussed by Professor Willems. Above all modules or subjects, bioethics is imperative as the basic knowledge of all aspects that should be covered in palliative care education. Substantially, a bioethic does not differ to other areas of medicine. However, in palliative care, besides knowledge and skills, the recognition of the needs of patient, particularly at the end of life, it needs moral attitudes that enable adequate decision making in relation to the unique sources of suffering, both patients and the families. So palliative care professionals need to have attitudes in seeing death not as a failure. Dying is a normal process. Disclosure and truth-telling, advanced care planning, therapeutic nihilism in terminal states, etc., etc. So who needs palliative care education done? A complex conditions, such the case that I shared above, need a comprehensive assessment and management. These tasks are too complicated to any specialty as it exceeds the expertise of any discipline. Core team of palliative care consists of doctors, nurses, social workers, chaplain, and volunteers. Also might be pharmacists. And other disciplines tend to be brought in as needed. and may be available only for consultation. So all involved in patients and the family care need palliative care education. As patients die in almost all areas of medicine and all levels of healthcare services, it is therefore essential for all doctors to be equipped with basic knowledge and skills and attitudes and behaviors necessary to provide the best care for patients in advanced diseases and the families. The nurse must learn that she or he will have the greatest contact with the patient and family, whether at home or in the institution. It is the nurse's primary responsibility to assist the patient to cope with the impact of the illnesses, to help patient environment to minimize loss of control, to support psychologically, and to reduce the symptoms. Palliative care social worker need to learn aspects related to the patient's and family's life, including personality and coping, family system pattern, and practical resources. And life-limiting illness can be extremely lonely experience. A palliative care spiritual counselor must learn to address the deep sense of isolation and help the patient and their loved ones find their own internal sense of comfort, strength, and balance. Education is also for the staff working in this institution to help them in developing the policy. And when suffering related to life-threatening diseases can be experienced along the disease trajectory, and most patients live their life at home. Unmet need of supportive care for aspect of human life is reported in those with life-remaining diseases, and this can be a palliative care engagement entrance in patients' care and call for a better health information and care planning. Primary palliative care can reach many more people in needs than that can specialist palliative care too. To just revert to them. So education on palliative care in undergraduate program, I think, is important. So basic primary palliative care, or we also usually call as a primary palliative care, as can be done in secondary health services. It can also be provided by primary specialist doctor for uncomplicated needs associated with life-limiting illnesses. It means that specialists also need basic training during their postgraduate study. Specialist palliative care, however, is a professional discipline with expert in complicated symptoms palliative care, in symptoms management, psychological and spiritual care, also in communication, and in a complex decision making, also to give expertise and caregiving support. Tertiary palliative care is indicated for patients with the most complex circumstances. I think this is usually provided in an academic center by a subspecialist. So this is various education program that so far available overseas. Forbes and Gibbons in 2008 stated that a significant minority of patients will need specialist palliative care. The remainder need their usual carer, as Professor Willems stated, to have the necessary skills to provide good generalist palliative care. So undergraduate education in palliative care will create an awareness and basic skills in palliative care for all doctors and nurses, I think. Yeah, and establishing an accredited of palliative care specialists, I think, is highly important in Indonesia to obtain standardized training and recognition, because generalists is not allowed to practice in secondary health services. Yeah. Specialty or subspecialty is a big argument in Indonesia. I would not specifically talk about it. I'm not sure as well how long this program can be initiated. But as we urgently need having an official recognition in the national education program, we plan to have postgraduate training. So we are planning to have 3 to 6 months fellowship program for a doctor and nurses. And I believe that in this moment, it is the most realistic program in responding the demand of palliative care in the community. This program also hope that can be ensure a consistent way of training a future palliative care, either specialist or subspecialist, which clearly define the competencies required to practice. We do hope that the Faculty of Medicine of Gadjah Mada, Universitas Gadjah Mada, after this meeting will show a serious effort toward palliative care official status and recognition, and develop, recognized training in palliative care. So, where palliative care spot to educate palliative care? Why? In my opinion, home is an ideal place where all aspects of the patient's and the family's life can be observed. Secondly, home is the place where most patients will eventually be cared and die. Palliative care education need to be conducted around the country, where remote areas, I think, that should be prioritized. Method. So you are all expert in methods. I will not discuss it a lot, but palliative care professionals need knowledge, skills, attitude, and behaviors to perform the best care. These 7 basic knowledge for undergraduate students, I think, is important. And to give them awareness of the palliative care issue, to let them recognize that the patient is approaching the end of life and know where to get is needed to enable participants to carry out a given task of a job under certain circumstances. It is not only lecture and tutorial, but also, I think, group discussion, role play, consultation, consultation with stimulated patient, supported observed palliative care unit, visits and clinical attachment. I think that's methods that important in delivering palliative care education. So, do we need innovation in our education methods? I think, for example, during anatomy dissection, because palliative care regarding life and dying both are values and precious. So while other disciplines learn from a cadaver about life, palliative care students can also learn about death, the dying process, and what and how the person experience process toward their death. Lecture and pain and symptoms management can be thought with ethical and psychological issues at the same time. Teamwork within interdisciplinary team can involve family care, family caregivers. Students can be paired with patients with cancer in prolonged periods to observe what their experience, what their needs, or their remaining life. A student also can spend time with patient and their families, attending appointments. So, for example, in a clinic, in the emergency room, and etc. So this is community education that has been done so far through institution or organization awareness program. So various measures via models we have been offered by palliative care services. We also attending ethnic group and religious group to introduce about palliative care. So many measures that wherever we can involve them, we ask them to introduce palliative care. The role of the community, is not only providing the tools that needed by patients who are care at home, but also they provide palliative care educations from what Prof. Tati said, Gadjah. So the community-based people that are willing to involve in palliative care. Yeah, I think that's all that I can share this afternoon. So they also, we treat them as the volunteers working not only at home, but also in hospital. So as a take-home message, I would say that challenges to develop palliative care in Indonesia stems from various aspects. Education is one of the major barriers distributing in its development. Accredited education is a paramount. Oh, sorry. It is very important to enable palliative care palliative care professionals are accepted and palliative care program can be integrated in the healthcare system. So educational sector, I think, is the most responsible to formalize the accredited education programs to provide palliative care professionals working in each level of healthcare system. So the referral system, not only from bottom to up, but also referral system up bottom will also work well. So then finally, the relief of suffering when cure is impossible should become the heart of all medical services. It is what every patient and family hopes for and has a right to expect. Therefore, each healthcare professional has responsibility to provide palliative care when it is indicated, as stated by Director in 1999. So this is the references that you can explore more. And this is my dream that one day I will say I'm a hospice and palliative medicine specialist. Thank you so much for your kind attention. Thank you.
Thank you, Dr. Maria, for the nice and important presentation. We would like to apologize also, Dr. Maria, because we had a trouble with the internet connection. But we really like to your presentation. And before we come to the question and answer session, we will have a presentation from Prof. Dick Willems. Dr. Maria, will you still be here for the question and answer session after this? So 40 minutes for Prof. Dick Willems. And yeah, I will not introduce again because we already have him in the morning, but Prof. Dick Willems is...
Can anybody hear my voice?
Yeah, very clearly and nicely, Doctor. Yes? Yeah?
Can anybody hear my voice, please?
Yes? Yes? Yes?
Thank you.
Yes, so we will have one presentation from Prof. Dick Willems, Dr. Maria, and then we will have the question and answer. Thank you.
Thank you.
Prof. Dick Willems, floor is yours.
Yes. Is it loud enough for you? Can you hear it? Okay.
Yes.
Okay.
Thank you.
Well, thank you for not introducing me again, because that would be a bit boring for everybody to introduce me 3 times. Thank you very much, Prof. Maria, for this very nice talk, and I will try to connect to it sometimes, because there are some similarities, and maybe also some things that we could share to improve things at both sides. So I would like to speak about the way in the last, I think, 20 years, teaching of palliative care in the Netherlands has developed, and I also address some of the things that are still not in place and that still have to be improved. Could I have the first slide, please? It's there but not there. Yes, that's it. So what I'd like to do is just 3 things, and I think I can easily do that within 40 minutes or half an hour. The first thing that I would like to talk about is the education framework that has been set up in the last couple of years about palliative care, and I think it's an important document that might also be useful for other countries. So that's the first part of my talk. The second one is quite brief, but maybe enough also. I will try to explain a little bit what happens in the medical curriculum, so how medical students encounter palliative care. And the last thing that I think is nice to speak about is the programs that we have to teach practicing physicians in the field, so physicians who are already practicing as either medical specialists or palliative care or general practitioners, to teach those physicians to become experts in palliative care. So those are the 3 elements of the outline. So please, the next slide. This is a slide in Dutch, but what it says is this is the educational framework for palliative care, version 2.0. And as you know, that's a low version. So usually you get to 15.0 or something. So we'll have new versions of the framework. It's work in development, but I found it important to, even though it is in Dutch, I think it's good to show it, because you see in the middle there's a whole list of educational, of levels of education that are addressed in the framework. And that's because the framework is fundamentally interprofessional. And I think that's one of the most innovative parts of it, really. So that's why I'd like to, and as you can see, this is a version from the 1st of September of last year. So it's really quite new. And unfortunately, there is not yet an English version of this, but that will probably come. So I can't advise you to look it up, because you'll have to be reading Dutch then. So next slide, please. So this educational framework for palliative care, which I already said is work in progress, has as the basic idea that education about palliative care should cover at least all nursing and medical professionals, but finally also all other people who are involved in palliative care. But this version, 2.0, is just about the nursing and the medical professional. Now it has education in 7 levels, because one of the nurses is in 2 levels, and it's talking about carers, so the people who do the basic care for patients. It's about nursing assistants, nurses, about the aims and the outcomes of teaching in the Bachelor of Medicine, Clerkship of Medicine, and for practicing physicians. And it finally ends up by a description of what's called EPAs, You will probably have heard that term before because it's used quite often in education. So it's about which activities in care can be entrusted to someone who has followed a certain training program. So that's what you call an entrustable activity. So in fact, giving an injection should be entrustable to a doctor and maybe to a nurse, but not to a carer. And so that's the concept of entrustable activities. So could go to the next slide, please. So as I already said, the basic idea is that palliative care is almost always interprofessional because of its holistic nature, because it addresses all kinds of issues from the medical issues until the spiritual issues. It should be interprofessional care, and it's completely logical then that you want teaching also to be interprofessional. And the ideal would be that palliative care is taught to groups of medical students, nurses, spiritual counselors, psychologists, everyone who's involved in any of the domains of palliative care. So this is the third one is not has a mistake. It says nurses two. No. It says nurses 2 times, but this should be medical students, the first one. So medical students should be taught together with nurses. And GPs together with medical specialists. And I don't know how, if you have any examples of interprofessional training in the medical faculties in Indonesia. It does occur, yeah. I mean, those are programs that we start doing in Holland. It's probably a starting thing in your country as well. And we do it in Amsterdam UMC. We have interprofessional learning between doctors and nurses, and I think now also between doctors and physiotherapists since about 3 years. But that's not focused on palliative care. It's focused on long-term complex care. So interprofessional training, and may I have the next? So what they're doing in this framework is that they take the CanMed's competencies and roles, and they just change it. You know, as you see in that one, in the center you have the medical expert in the left one. So what they've done for this framework is that they replace the medical expert with healthcare worker in general. But they still use the 7 competencies, the 7 CanMed's competencies, or the 6, I must say, yeah, 6. So the idea is, and I think that's a very wise idea, because that makes it possible to link the education of the different professions to each other, because they're all programs about health advocacy, about scholars, about professionals, about professional behavior and things like that. So that's essentially, I think, the major step, that you look at similar competencies in the different professions. So can I have the next slide, please? So that's the system for all the 7 educational levels that are addressed in the framework. The old framework, the CanMed's roles are used, and and then each competence. So you have these CanMed's competences, and each competence is translated into visible or observable actions that a student should be able to display. And those visible, observable actions are what allows you to assess if they have reached the desired level. So, and that's it's a very systematic way of looking at how to construct a teaching program. So these these visible, observable actions is in fact the same as the entrustable activities that I was talking about earlier. So that's in fact the system. That's the logic of a framework that's interprofessional in nature. and that's linked to palliative care. So can I have my next slide, please? I'll just give you a few examples of how they deal with this. I can't give them all because it's a document that's really, it's about 60 pages long, and it has all the competencies for all of them, so I can't go into very much detail. But I'll just give you the example of nursing assistants. So what the framework says about the teaching goals and competencies and activities of nursing assistants. And I'll just say it for two CanMeds roles. The first one is the CanMeds role called communicator. And then the document specifies that the nursing assistant should develop the competency to communicate with patients and family in a personalized and a professional way. So we've been speaking about personalization this morning already. And that's one of the competencies that nursing assistants also should have. So not only doctors, but also nursing assistants. And they should also be able to signal ethical and spiritual problems in patient and family, and discuss those signals with the professional team, so with the palliative care team. So that's an example of the competencies that nursing assistants should have. And then they're translated into visible, observable, and accessible actions, such as that the nursing assistant should be able to recognize the different ways in which people cope with the terminal disease and with suffering, and that she will adapt her behavior accordingly and test if someone is able to do this. So that's what the nursing assistant should be able to do. And she or he, it's often she, nursing assistant, but let's say he too, to be a bit gender neutral. Let's say he should also be able to show empathy by listening to patients and family, and by asking appropriate questions. So those are the activities that they should be able to do. I'll have another example about nursing assistants. That's the next one. Under the role, the CanMeds role professional that you may have heard of, so the role that we expect every healthcare worker to be able to perform, and that's in fact the basis of every medical curriculum. So under this role of the professional, the nursing assistant should have the competency to act ethically and with integrity according to professional standards of his or her profession. And they should also be open and transparent about how they permanently develop their own competencies. And this again is translated into visible actions. So you have a table of visible actions, so you should be able to see that the person is able to reflect and to give and receive feedback and to support team members and that kind of things. So these are two examples of two CanMeds competencies. I hope you all know what the CanMeds. I just realized that maybe not everybody knows what it is, but the CanMeds roles are the. Does everybody know what it? Who doesn't know what CanMeds roles are? I'm not sure. I'm talking and now I realize that I may be talking as. Do you think everybody knows here? They're quite known or not? You don't know? Sorry? No, it's the Canadian Medical Association description of the role of doctors. They started with doctors. So they said the doctor has to be a medical expert, a communicator, a manager, and he has to have competencies in professional behavior, and there were two others, organization and teaching, I think. Oh, I'm sorry I didn't say that before. But that's what these roles are about. So they're specifying what every doctor should be able to do. And these roles are the basis, I think, also of many medical curriculums in Indonesia. But they're not that now. So maybe that's so these are the 7 roles, and they're specified for every profession. So there's one role that says professional behavior, and that is what's described here for nursing assistants. Can I have the next slide, please? So here's the other role again, or now I'm going to the bachelors of medicine. So that's one of the others of the 7 professions that the document describes. And here again, we have the same basic structure of the roles that doctors should be able to perform. So the medical, the communicator, the professional behavior, the organizer, the teacher, everything. So I've taken the same role for the bachelor as for the nursing assistant, and so what the Bachelor of Medicine should learn is how to speak with the patient and with the family about emotionally disturbing events in the course of the palliative disease, should have a proactive role in the planning of care, and there are more and other competencies. I won't list them all because that's very boring. And that again is translated into accessible actions, such as that is able to discuss issues on the 4 dimensions of palliative care: the psychological, the physical, the social, and the spiritual, and take into account culture and everything. And also, same as with the nursing assistant, the bachelor in medicine should also be able to show empathy and able to support patient and family in emotional trouble. So these are typically things that people can learn together. Right? Now my last example has exactly the same again. Can I have the next, please? That's again about the professional role, the role that specifies professional behavior. It's one of the other of the 7 CanMed's Canadian Medical Association roles, I must say. Yeah. So then again, the Bachelor in Medicine should show adequate personal and interpersonal behavior in palliative care, and is aware of his own limitations, and is also reflexive, so can think about how he behaves and how she behaves. And again, this is translated into visible and accessible actions. Conscious of their own attitudes about life and death and how that influences the care of the patient, and they can speak about existential and spiritual experiences. So this is, in fact, the structure is to show you how you can set up a framework about education in palliative care that's applicable to many professions, and that can stimulate interprofessional care. So I hope there will be a translation of the framework soon, and then anyone who wants it could look at it to get inspiration from it, not to copy it, but to work out a version of their own. So I'd like to have, can I have my next slide, please? I'm going to what's done in the medical curriculum now in the Netherlands. Just quite briefly, but a few things. So could I have my next slide, please? So I think in the Netherlands, we can say that all medical schools have palliative care somewhere in their curriculum. There's really no bachelor training where there's no palliative care, I think. In fact, it is in the obligatory aims of medical education as specified by the Dutch Medical Association. So you have to be accredited as a training, you have to have elements of palliative care. So in that sense, it may be more advanced than what Dr. Maria told about in her talk. So, so they all do, I think, the physical and the psychosocial aspects of palliative care. I don't think all medical schools have teaching about spiritual and existential elements of palliative care. That's quite rare, I think, still. So but the interesting, and that might be a difference with what Dr. Maria was talking about, the organization of the teaching is not so much in specific palliative care modules. So it is not, we don't have a specific module for palliative care, but palliative care is integrated in other blocks. It's a bit like very often medical ethics and bioethics. It's usually also integrated in other reason. The other reason is that it is also logical, because if you say that palliative care is something that has to be learned, that is in every specialty in medicine, then it's also logical to teach it in every specialty. So that's why we, I think, almost everywhere don't have separate blocks of palliative care, but only as part of other blocks. So, for instance, in the Amsterdam Amsterdam UMC, we have lectures about palliative care for COPD in the pulmonology block, and we'll have the same about palliative care and problems in palliative care in patients with ALS, like the patient I was speaking about this morning, in the neurology block. And there's place for more general talks about and lectures about palliative care in the general practice block. So we do things there about, well, the things that we've been talking about this morning, about the principles and the basic values of palliative care. So this is how palliative care comes back in the bachelor phase in the medical curriculum. So maybe I can have the next slide. And there's also, it's not really medals. Palliative care is discussed a lot in the clerkship phase, but again, it's linked to the clinical rotations. So there's always attention for palliative care patients in the internal medicine rotations and in the oncology rotations. And there's also, let's say, face-to-face education about that. So it's practical partly and practical class education. I think, to give you an example, we just started, I think, 3 or 4 years ago to teach about spiritual issues related to giving meaning to disease and to suffering to third-year medical students. So that's in the bachelor phase again. And we do that together, and that's a very interesting experience. We do that with the Department of Spiritual Care of the hospital. And they have, in that department, there are both Christian spiritual counselors and Islamic spiritual counselors, and so-called humanistic spiritual counselors. So spiritual counselors for people who have no religious affiliation. And as you will know, probably that many countries in Europe and Holland as well is getting less and less religious. So we have, I think, about 50% of the population now says that they have a religious affiliation. So I think that, and we must say, I think that interprofessional training is work in progress in Holland as it will probably be here. So that's what I'd like to say about the medical curriculum. So there is some palliative care teaching going on, but it is spread over the most important other specialties. So then, can I have my next one? So I'd like to end, and that's about 5 minutes, I think, about teaching palliative care to practicing physicians. Because I've been involved with doing that for about 15, 20 years. And you can have the next slide, please. So we have in the Netherlands since about 20 years, I think, there's 2 extensive training programs for practicing doctors. So people who are already, sometimes they have been in practice for about 20 years and then now start doing this training program. We have 2 programs. One is for medical specialists. They have a program of 9 whole days of palliative care teaching. And the general practitioners and nursing home physicians have 20 whole days Now, you may wonder why that difference. Of course, because medical specialists never have time, so they won't have time to spend 20 days. And you could also think that GPs have more to learn, but I don't think that's the case. And in fact, the second one is also sometimes followed by medical specialists because it's more advanced than the first one. So it goes deeper into a lot of the stuff that's taught. But it's already, and these are courses that are attended by many doctors. They're always overbooked. So, and they're there every year, and or every 2 years. So they have and they've become very demanded. And one of the attractions, of course, is that it is sufficient for specialists and GPs for their obligatory continuous medical education points. I don't know if, do you have a system like that here? CME points? Yeah, right. So for their accreditation as a doctor, they need to spend so much time in education. And then especially the second training is enough for the GPs. So if they do that, they have enough for their 2 years. That makes it more attractive, of course, to do it too. And the interesting thing of the training programs is that it eventually may lead, in many cases, it's lead to a position as a palliative care consultant in a hospital or in primary care. So these people are usually the central GP or specialist in a palliative care consulting team. So they're in fact the Dutch version of the palliative care specialist. Even though we don't have a formal specialism, we do have these experts who are more trained in palliative care. So I'd like to just show you a little bit what these people get as elements of their teaching. Can I have the next, please? So what they are taught about is the foundations and philosophy of palliative care. So I think they spend a day for what I did in about an hour this morning. So it's a bit more deepened, I think, and so more extensive. They have things about the organization of palliative care. And then there's a lot of attention, of course, because these are the medical experts, for the important symptoms in palliative care. And so those may be pain, it may be depression, which is a very current symptom, of course. Dyspnea, delirium is an important issue. Gastrointestinal symptoms, and maybe the most important one is, the most common one is fatigue, of course. That's the most, people tend to think that pain is the most common symptom in palliative care, but that's not the case. It's fatigue that's most common. And it's also very disturbing for people. So can I have the next one? Don't know if this. So those are the main symptoms, I think, that are discussed. And they also have teaching in ethical issues in palliative care. Palliative care for children is one of the issues, even though it's rare. But as Dr. Mariels, I think she who said that even though it's rare, it's very disturbing and hard to do. I've had a few children in my general practice that died from cancer, and I will never forget those children. It's a really emotional way of part of care. So that's a separate subject in these courses. Mental incompetence is a separate issue, because as you know, quite a few patients in the course of palliative care become incapable, and so they become incompetent. Bereavement, also in children, I think that's an important issue that is sometimes forgotten, the bereavement of children. We look very often at spouses, but children very often need a lot of help in coping with the death of a parent, especially if they're young. They will need a lot of help with that. Communication, and a last point, and we haven't addressed that up to now, but one of the real important issues in palliative care also is care for the professional caregiver. Because as almost all speakers have said, palliative care is a very rewarding part of medicine and of healthcare, but it's also very emotionally charging and burdening sometimes for doctors and for nurses and for everybody else. So it's care for the carers is really one of the central aims also of palliative care that we haven't maybe addressed enough. But it's part of this training program for specialists and general physicians. So can I have the next one? Since we're talking, we're at the Department of Bioethics, I thought it would be nice to say a few words about the ethics training that we give to these doctors, and I've been involved with that for the last 20 years, giving the ethics teaching. And what we do we have one whole day of ethics teaching, and that's quite a lot, in which we give an introduction to ethics, to, let's say, concepts of good death in history, but also within cultures. So we try to approach it from different cultural viewpoints, and to what we call moral case deliberation methods. So the way you can discuss ethical issues in a group of doctors, or preferably in an interprofessional group. And then what we also do in the afternoon of that day is that the doctors discuss ethically difficult cases that they encountered in their practice. So, and these are not only cases of euthanasia, it's sometimes also cases of let's say conflict between spouses, and one of them is dying, and so there's all kinds of ethical issues. Issues of addiction and how to deal with that. I mean, there's so much around. I'll be speaking a little bit about it tomorrow. And as a form of assessment of the ethics program, we have the doctors have to write an essay about a good and a bad death that they have experienced as doctors. Not for themselves, of course, because they're still in the training, but with their patients. And that's really something nice to. It's a nice idea to have them write about that, because that makes them think about their role in providing a good end of life for their patients. So, and especially describing a bad death, so a death that they think should have gone differently, is very helpful for them, and they like writing these essays a lot. So that's a bit. Can I have the next one? Oh yeah, this is the image that I always use in the training. Does anyone know who this is? Who would this guy be? The guy with the finger, I mean. He's going to die, though. You don't know. He doesn't look terminal, maybe, but he's going to die. Nobody knows. The oldest Greek philosopher, Socrates. Yeah, this is Socrates, who is just on his deathbed, but you see, he's not dying from natural causes, as you probably know. He didn't die from natural causes, but he had to drink a lethal poison, and but he's still teaching until his last minute. He was a real teacher, you know. We try to be teachers, but this was a real teacher. At the end, until the end of his life, he was teaching before taking the. And in fact, he described this as the best way of dying: inactivity, doing what you always did, and then, well, maybe not by poison, but then starve. That was, in fact, his idea about dying. Can I have my next slide, please? So this is what I already told you. The next, please. So the teaching methods there, I won't say much about that, but it's very much focused in this advanced course for doctors. It's very much focused on self-learning techniques. They also have to develop a quality improvement plan for palliative care in their own working context. So how can they improve palliative care in the hospital where they work, or in the GP setting where they work? They do practical exercises. And there's also a lot of attention for debriefing. So that's part of the what I said, the care for the caregivers. So they debrief if they've had particularly emotionally charging things like treating the image that both of the speakers showed of the woman with advanced breast cancer. I think that's emotionally disturbing, even though the reactions here were quite calm. It must be emotionally disturbing. Okay, next slide, please. So that's my conclusion. I think it's the framework that has been set up, and I think it would be good if the Indonesian Palliative Care Association also try to set up a framework like that. It helps a lot for improving monodisciplinary training, but especially also interprofessional teaching. And that, as I've already said a few times, is probably crucial for the field of palliative care. So, and I think it's necessary in all levels of healthcare, so from the nursing assistant and the carer up to the medical specialist in the academic hospital, they all need teaching in palliative care. But that's work in progress everywhere. It's not only here, it's also in countries like my country, it's work in progress. And I think the teaching of practicing physicians is one of the best ways to promote palliative care. So people who are already in the field. So that's why I said a bit more about the program that we have for practicing physicians. So that was my contribution. Was it 40 minutes or was I about? It was a bit more, wasn't it? Still, I'm sorry for that.
Thank you, Prof. Dick Willems, for this important presentation, and really interesting to know how it is in the Netherlands and also how the Canadian Medical Association sets the competencies. So now we come to the question and answer session. We are here still with Dr. Maria from the Dharmais Cancer Hospital, and then with Prof. Dick Willems from the Amsterdam University Medical Center. So for the participants here or also online who have a question either in English or in Indonesia, please, you are welcome to ask question. Ada yang di sini nggak? Oke, Mas Bagas. So,
thank you. All right. Yeah. Thank you for the time, Ms. Tiwi. I would like to ask or also share my experience while meeting with medical students from my university, Unsud in Purwokerto. I think I have seen one or two medical students feeling very uneasy about a patient who were discharged earlier from the hospital for a palliative home care approach, because the student think that there should be more that we can do to cure the patients or something. And I think it could be also related to the very lacking of palliative care teaching in the bachelor phase, while in our university we only have like 100 or 150 minutes of palliative care, and it is also in the bioethics block, so I'm not really sure if it is being scattered all around the other blocks as well, because maybe the awareness of the importance of teaching palliative care is also a little bit lacking in our city. So I am really curious about how the medical students in Jakarta or in Gadjah is dealing with this kind of cases. Thank you.
So the question is
for Dr. Maria and also maybe from for the Gadjah teachers.
Yeah.
Yeah.
Yeah. So we have also participants from the medical education, I think, or lecturers from Gadjah or other cities who have maybe experience and would like to give some comments about this question or other.
Thank you. Can I respond?
Yes, please, Doctor.
Okay, thank you for that question. Yeah, I teach undergraduate students in medicine. They learn palliative care under palliative care block, which is about 2 weeks. Learn about basic palliative care, and then afterward, after the module, and then they ask come to hospital, and then have little bit round in a clinic, and then they visit patients at home. So basically, a 2 weeks module, I think, is not much for them. And then in the postgraduate study, they have a week's placement in palliative care units. So I think that is also not enough to give a basic basic skills, and knowledge might be okay, but for having enough skills to practice in palliative care, even in primary health services, is not enough. Yeah, that is in few medical faculty of medicine in few university in Jakarta. I do not have experience in other cities. Might be from Jogja, Ibu Tanti, or Ibu Tanti still there?
Tanti is not here anymore, I think.
Okay.
Huh? Ah, yeah.
Yeah, thank you. I would like to introduce myself. I am Yodang. I'm a nursing lecturer from Universitas 19 November Kuala Lumpur, Sulawesi Tenggara. It's a long far away from here. I'm teaching palliative care in nursing bachelor programs since 2017. Actually, Dr. Maria is my senior because I am graduated in the same university, at Readers University, in Master of Palliative Care programs. Wow. Yeah. My experience teaching in palliative care for nursing is really challenging. First of all, because palliative care is new subject in nursing, because palliative introduced since 2016 under IPNI. It's like Association for Nursing Education in Indonesia. And the other challenges in teaching palliative care, because mostly lecture in teaching palliative care, not educated in palliative care. Yeah, that's why it's how to fulfill the core competence for students is really, yeah, I think it's difficult, I think, because beside that, because a resource like a textbook is really what is unaffordable for lecture in Indonesia, particularly in institution in the remote areas. And talking about the palliative care in general in education, not only for nursing and also for medicals, but also for other health professionals. The challenging one is because palliative care is interprofessional practicing, and that's why we need to practicing palliative care in interprofessional education also. And the challenging one, because as far as I know, only UGMs already implemented interprofessional education, but at other university, I don't know. Yeah, and that's why it's really hard when we implement palliative care in clinics, in clinical settings, because because in each profession has different roles, how to treat the patients. Yeah. Beside that, there are many health professionals also involved in palliative care, and some of them doesn't exist in Indonesia. Take examples like bereavement counselor. In Indonesia, we didn't have a bereavement counselor. Talking about bereavement is really important, not only for patient but also the family. Because in bereavement counseling, there are some diagnoses we need to put relate to the ICD-10 or ICD-11, something like that. And beside that, from education perspective, also regulation in Indonesia. Yeah, take example, like how the provision of for painkiller. Yeah, it is challenging for Indonesia because it's beside that, who is prescribe the medicines, because in some countries nurses already have authority to prescribe this kind of medicines for painkiller for patient in palliative medicines, palliative care, I think. And yeah, it's our challenge how to improve palliative care in Indonesia, I think. Yeah, it's my sharing for all participants here. Thank you.
For the sharing from Sulawesi, which is in the east of Indonesia, and maybe Prof. Dick has also some.
Well, yes, I was also curious to know what Dr. Maria thinks of the alternative of having a palliative care block or module separated, or to have palliative care in all the separate blocks, which has obviously the disadvantage that you don't know what the quality of the teaching will be in those different blocks. But well, I'd just like to have your view on what you think is the best way of doing it.
Is it for me?
Yes.
Sorry,
yes.
I can
yes.
hear you. Yes. Yeah. What I was saying was, in the Faculty of Medicine that I teach, there is a separate block for undergraduate.
I know. Yes.
It takes 2 weeks modules, and it's not under any other blocks. That is separate blocks.
Yeah. Yeah.
Yeah.
The problem.
And that's why.
Yes. Well, our problem in Holland is that they have to be a minimum of 8 weeks, and you never get a block of 8 weeks from the organization, because then you will have to take it from someone else. So that's our predicament a little bit. You're lucky to be able to do a 2 weeks block, maybe.
Yeah.
Yeah.
Yeah. I'm not developing that module, only invited as the lecturer to give, basic knowledge in palliative care. But yeah, it's good to know Professor Willems, and let me discuss with the other lecturer how to develop 2 weeks blocks.
I would be interested to know. Yes.
Yeah.
Yes.
Yeah. Okay.
Interesting to know how it is from different places, and to reflect a bit about one module versus integrated in different module, because also like from Sulawesi said that in Indonesia there are challenges about the teachers that are not yet trained in palliative care, and it's not yet, especially in the remote areas. So if you would like still to share or to discuss about this, or have a new question, please. There are still about 40 people online, but I don't see any question yet. And in the studio around 30, so it's really nice to have many participants in the afternoon. Maybe if there are no questions yet, there are some questions from before which has not been addressed. So one was from Dwi Novrianda, University of Andalas, maybe from the sessions in the morning, and the question was, how does palliative care in pediatric cancer in Indonesia? Maybe Dr.
That's a question for Bu Yati, maybe.
Prof. Yati or Dr. Maria, maybe if you would like to
Okay.
share a bit. Thank you.
Okay, thank you for that question. I work in a cancer center hospital, a national cancer center as well. We have palliative care for pediatrics. So we have, unfortunately, one of the pediatricians who are trained in palliative care is just resigned. And all the pediatric palliative care patients now is under adult palliative care services. So we trained pediatric nurses, and we have one pediatric psychologist, but we don't have specific social worker. So at the moment, they are under adult palliative care services. And also in Jakarta, I noticed that there is private palliative care services, which name Rachel House. This is a private pediatric palliative care service. This is free for all services, and they collaboratively with palliative care in Dharmais Cancer Hospital, and also with Indonesian Cancer Foundation. So the patient who are previously care as inpatient in Dharmais Cancer Hospital, we refer this patient to Rachel House, and they look after the patients at home. Yeah.
Can I say something about pediatric palliative care in the Netherlands? Because we have a very active group of physicians in Groningen in the north of pediatricians who set up a consultation service for pediatric palliative care for the whole country. So they function as a sort of a consultation group for both pediatricians and also general practitioners who care for children with cancer in the palliative phase. Because the problem with that form of care is that it's quite rare. Many primary care physicians never have children with cancer in their practice. I've personally had it was by accident. I've had 2 children with cancer in my practice, and I think it would have been very helpful in the time to have a consultation team that I could have consulted about certain issues. So, and not every hospital has a palliative care team for children, but they do refer to this team in Groningen, which is based in Groningen. So I think consultation is a very important issue in pediatric palliative care.
Thank you, Prof. Dick. Maybe this also already answer the question from the morning from Devi Novita Cahyaningrum from Sarjito Hospital. The question was, how about palliative care for pediatrics? So maybe this already cover also her questions. Yeah, is there still any question from the audience in the studio or sharing experience? We still have maybe 4 minutes to go. Yeah? Yeah. Sister Josephine.
I would like to ask to Dr. Maria, with the pediatric for care process, how to handle with the grieving process of the parents, bereavement.
Right. Yeah. All right. Yes, grieving process for in pediatric patients is more complicated. It's more challenges, and mostly we are dealing with the parents more than to the patient. Sometimes the patient is, they are still very, what you call it, very naive and having different understanding about death, right? So it is also very important to skills in talking with the children about that. But it is more difficult to talk about children death to the family, to the mother especially. Yeah, so we have a pediatric psychologist who always accompany and always giving support to the mother, especially, and also to the siblings. But it is very important to remind the pediatrician not to refer the patient at the very end of life. It is much easier for us to deal with the grieving process if the patients are referred to palliative care in an earlier stage. I think one of the key. So we get to know the patients and the families well. And when the patient is deteriorating, we kind of we have preparing for a quite long period. And it is very, everybody I think agree that losing a children is losing a future, while losing a parents is losing the past. So this is why it is very important to adequate support to the mother especially, and the siblings, but also to the father of palliative care pediatric.
Okay, thank you. It should be like a teamwork with like a group, group therapies, like that. If, for example,
Yes,
as several parents where the children is diagnosed as the cancer, then be able to use like a strategy of the group teaching or group accompanying, group discussing like this. Is that really helpful, isn't it?
Yes, Dr. Sister Josephine. So palliative care is always work as a team.
Yeah.
And we also invite volunteers, in the hospital that I work for, the volunteers mostly are the parents who have experience losing their children.
Thank you.
We have to be very careful also to involve them. If they are not finished with their grieving period, then it is very, painful for them as well. So we have to be very careful to choose which parents are ready to give support to other parents.
Okay, thank you very much. Can I have one more question, Dr. Maria? With the cases, with the cases that the physician not really able to express or to inform that someone get the cancer, like the cases. Do you remember our cases that the person right away moved to Dharmais because the physician unable to say polite maybe, or maybe not really okay for the patient. Even the patient still in a denial state, then the patient kind of express it and like reflecting on the physician, how she or he unable to communicate well, then kind of try to move to the other physician and move to the other hospital to get another diagnosis. How do you give? How can we prepare, or how can we put on this kind of cases as learning from the experience? Thank you.
Right. Thank you, Sister Josephine. That's a very good question. So please do not push patient to know what is happening. So each patient has right to understand what is the real condition. But on the other hand, patient also have not to know. So you have to assess carefully with the patient. You start with how she or he understand about what is happening, about the disease, about the condition, about the latest test, for example. And then you have to ask, how far do you want to know? If they want to know, then you have to ask next question, whether she or he is ready to know. If something that we will to disclose is not as what he or she expect. So it must be very careful. Once again, we have to remember that each patient has right to know, but also has right not to know. Yeah. In the case that the patient, is not ready to know, that we have to wait, or you can ask to whom you have to share with the information if it is urgent. Yeah.
Thank you. I hope that all of the physicians, especially the oncologists, able to using the communication well to know and the thorough assessment to give the patient in the right place, right time, to inform as a patient have a right to know or to not to know. Thank you.
Yes, unfortunately, most other specialists are not have enough time, to explain clearly with the patient, even with the goal of the treatment that they plan. That's why many patients are, they are dissatisfied with our communication as a doctor. That's why I suggest that all doctors should learn more about how to communicate with patients as the patients demand.
Sister Josephine for the question and also Dr. Maria for the answers. I think we have come to an end of this session. And now that we have a bit of a clear take-home message from Dr. Maria, also from Prof. Dick Willems, the nature of the palliative care, how it is interdisciplinary and how there are different competencies related, and what are the options to establish a palliative care education within the profession or separate from the profession or ongoing with the practitioners. And we have also already the description and knowledge about the different challenges in Netherlands, also from different settings that Dr. Maria presented, and also from the audience from Central Java, from Purwokerto, from Sulawesi. So we are very thankful, Dr. Maria and also Prof. Dick Willems, for the session today. We would like also to thank the participants for still bearing with us here. Can we have please a big applause for Dr. Maria and also Prof. Dick Willems. And I will give back the station to the MC.
Excellencies, distinguished guests, ladies and gentlemen, the discussion and today's symposium has been concluded. And we'd like to thank all of you, especially for all of our speakers, Professor Dr. Dick Willems, Dr. Maria Astheria Witjaksono, Master of Palliative Care, and for our earlier speaker that has left already, Ibu Dr. Christantie Effendy, Sarjana Keperawatan, Magister Kesehatan. And we are also very honored to be joined by our seniors in bioethics who have joined us in person today, Prof. Narto, Prof. Yati, Prof. Rika, Romokus, and all of our seniors in bioethics that we humbly apologize for we cannot mention one by one. And lastly, but surely not least, we are very tremendously grateful for all of our guests and participants who have joined us online and also offline here with us today. May we all can make the best of today's session, and we are going back again tomorrow with our third and fourth session of our symposium with the theme of palliative care business and its ethical issues, and also about bioethics and palliative care with our speakers, again, Professor Dr. Dick Willems, and also will become accompanied by Dr. Darwito Sarjana Hukum, spesialis bedah, konsultan onkologi, and also Sante de Voogd, PhD from Amsterdam University Medical Centers. And we thank all of you for your kind attention, and we apologize for any mistakes and troubles that have happened today. And we are hopeful to have you again here tomorrow with us here, offline or maybe online in the same link. And selamat sore, good evening. Assalamualaikum warahmatullahi wabarakatuh.
Pamit ya. Terima kasih.
Terima kasih.
Bye.
Terima kasih.
Mohon izin live ya.
Astheria.
Terima kasih
Ya, dokter,
Bapak.
terima kasih.
Terima kasih.